Good morning, dear colleagues. I'm happy to see you all healthy. I hope that you've rested well last night. And I hope that we didn't overload you with the information and all the events. Andrea, I kindly ask you to co-chair. And there was a request from our technical staff. All presenters from the plenary session number 1, please bring your presentations to our technical assistants. This is the second day of our conference, and the first plenary session is about the experience of countries in implementing national TB strategies. And the first presentation will be made about epidemiological situation of tuberculosis in Tajikistan by the director of the Republican Center for Protection of Population from Tuberculosis of the Republic of Tajikistan, Mahmatov Abdullah. Dear colleagues, dear participants of the conference, I would like to present the progress of implementation of National Program for Protection of Population from Tuberculosis in the Republic of Tajikistan. On this slide, there is a structure of TB protection system in Tajikistan. We have 3 provinces in the country and 6 cities and districts, and in all of them, centers for protection of the population from tuberculosis have been organized. Also, our country has 1,500 TB beds. Beginning in 2012, we have noted a decrease in the number of TB beds. So back then it was 2,500, and we reduced them by 1,000, and now we have 1,500 TB beds. In the penitentiary system, there are 190 beds out of this 1,500 TB beds. Here we're showing national programs available now. We're implementing the 5th program now that was approved in 2021. The main goal of this program is to reduce the burden of TB and its influence on overall socioeconomic development of our country. And also universal access to quality diagnostics and treatment of all forms of TB, including latent TB, which will result in decrease in mortality and morbidity and development of resistant TB forms. I apologize. Thank you. So the key indicators of the program include reduction in mortality by the end of the implementation of the program, and that is by 2025 by 35%, and a reduction in incidence by 30%. And the share of DRTB needs to be less than 10% in new cases, and relapse is lower than 35%. Right now, DRTB is 19% in new cases. Also, universal access to diagnostics and treatment of all forms of TB, including MDR-TB. Here are the indicators that are available in our program. On this slide, we're showing the TB incidence in the country beginning in 2006. The peak of incidence was in 2007, when we notified 85.1 per 100,000 population. But we can observe stable decrease in incidence in the recent 2 years. Again, due to COVID epidemics, we had significant reduction in incidence, and in the recent 2 years, this percentage remains at the value of 40.5, 40.3. We could say, although this is a preliminary conclusion, we have improved the detection rate. So that's why we might have an increase in incidence as compared to the recent 2 years. So this is the incidence and the level of our provinces. We only have 3 provinces. We have the highest incidence in Uzbekistan Autonomous Province. This is about 64 per 100,000. Then Khatlon, and in the north of the country we have the lowest values. In Sokt province, 28.3 cases per 100,000. The mortality is another indicator of the program. We were able to reduce mortality due to TB, and according to recent data, there is a stable decline, and by 2021 it was 1.3 per 100,000 people. According to our strategy, by 2035, the country is to reduce incidence by 90% as compared to the indicator in 2015, and that should equal 0.2 per 100,000. Presenter probably meant mortality, not incidence. Now, notification of co-infection cases. About 98% of all notified cases are tested for HIV, and this is a compulsory requirement. The highest values were in 2018. There was about 3.7% of all notified cases, but has been the same level in the following years. Well, we should say that 70% of people with HIV of prevention with isoniazid. Maybe this is one of the reasons why we see a decline in incidence in this category of patients. The key risk groups that in TB, these are labor migrants, about 15%, and contacts, also about 15%. Then co-infection, and then prisoners, and those people with other diseases. Labor migrants, their numbers are decreasing in 2012 and 2013. Their proportion was 18 to 20% of all detected cases, but in recent years this indicator is going down as well. Notification and coverage with treatment of drug-sensitive TB cases. We started in 2009. We had pilot districts. We took only, I'm sorry, this is for drug-resistant TB. We only had about 500 patients, and then we gradually increased the coverage with treatment. Now, the level of detection is 545 and eventually 532 patients. The coverage is 96.2. All detected cases and patients are notified. We have no problems with drug supply or any other problems. Effectiveness of treatment of DRTB is one of the indicators of our program. It was identified that the effectiveness of treatment success was supposed to be 75% according to our program. Now we show the data for the recent 3 years. There is a tendency towards increase of this indicator. Treatment success in 2020. Well, we have closed the chapter on this cohort, and according to our estimates, it's 80.6%. As compared to 2018, we see improvement of this indicator by 8.1%. And I believe that this is a good result. If we isolate patients with XDR-TB in this number, and there were only 52 patients in the cohort and 41 successful treatment, so the treatment success would be 75%, but the mortality was 17% among these patients, only in 2 patients, and that is 3.8%. Their treatment failed. Treatment regimens for DRTB. Right now, there's individualized regimen, and there are also a regimen with an operational study, and also MSDR, also within the framework of an operational study. For shortened regimens, we included 107 patients. 93 of them successfully completed their treatment. That equals to 87.7%. Died 2.8%, lost to follow-up 1.8%, treatment failure 2.85 were excluded from the cohort. In the new cohort, we have 81 patients. 1 of them is lost to follow-up. 3 were excluded from the cohort because their resistance to drugs in the treatment regimen were confirmed through DST. So into BPAL cohort, we included 57 patients, 81.6% had successful treatment, died 7.9%, loss of follow-up 2.6%, and 7.9 were excluded from the cohort because they had resistance to drugs in this treatment regimen. And at the moment, 19 patients are still continuing their treatment. So modern TB diagnostic methods include gene experts. We have 59 machines at the moment. But if you compare, in 2013 we had 14 machines. Almost all larger cities and districts have gene experts installed. We have only 7 districts that remain, but their population size is small, and they use services from nearby districts. The key results of the program in recent years, we've been noticing in decrease in incidence and mortality from TB. We're actively implementing innovative approaches to TB diagnostics, and we use a rapid tests such as Gene Expert Ultra, Gene Expert using XDR cartridges, but then our country has recently ran out of these cartridges. With support from USAID, we purchased 3 digital portable machines with artificial intelligence, which helps us to detect TB at early stages. Using the resources of the grant from the Global Fund, last week we received 12 additional of these machines. We will distribute them to our regions. There's also an increase, although by a little bit, there's increase in government financing of the TB control service. I should also say that beginning in 2021, the country started purchasing drugs fully at the expense of the state budget. That applies to second-line drugs. And also, starting this year, we're purchasing drugs for treatment of monoresistant, polyresistant TB, and also reagents. The guidelines for diagnostic and treatment of LTBI was approved. Also, there's an increase in the number of examinations, of contacts with technical support of NGOs. The country, you could say, has NGOs working, and their activities are focused on TB. That is AFIF NPO, sub-TB partnership that help to investigate and examine contacts. As I mentioned earlier, we have achieved a high percent of treatment of TB and TRTB, and that is 95%, and drug-sensitive TB among TRTB, that is 80.6%. This is about LTBI. As I said earlier, we have had the guidelines approved at the Ministry of Health in 2021. These are the new guidelines that were printed out and distributed in the districts and PHC facilities for family physicians and also for TB service staff, and with technical support from USAID project. In 18 pilot districts, we're implementing treatment of LTBI, and the plan is to cover the whole country eventually. Also, capacity building of specialists was organized. The TOTs were organized, and seven trainings for PHC, health professionals, family doctors, and doctors from TB centers and HIV service centers. Recording and reporting forms and electronic database for LTBI were printed out, and the electronic database is being implemented in order to detect cases of LTBI. A PRICAS, or order of the Ministry of Health, was issued on free additional examination of contacts so that we can rule out active TB and start the treatment for LTBI. Difficulties and challenges. Due to COVID, our goals have not been achieved fully, and everybody knows this fact very well, and there's insufficient coverage with screening and diagnosis of contacts and persons with presumptive TB, lack of public awareness, especially among young people and women, especially in remote districts of the country, on detecting symptoms, diagnostics, treatment, and prevention of TB. Another problem that still remains is that not all the centers for protection of the population from TB have enough staffing. There's some outflow of these specialists into other health sector areas, and so they're understaffed. And there's high level of stigma and discrimination towards patients with TB and their relatives. Also, there's insufficient financing. Although the country is allocating the money to implement the national program, but this is not enough. Mainly, the program is implemented more at the expense of the funds from international donors. Thank you for your attention. Ready for questions. do so, but she sent her presentation, which is called Tuberculosis in the Russian Federation, Achievements and Prospects.
Уважаемые коллеги, уважаемая Наргиз Нусратовна, дорогие друзья, от имени Министерства здравоохранения Российской Федерации, от имени всех педиатров России, а также коллектива Национального медицинского и фельдшерского пульмонологии и инфекционных заболеваний Минздрава России, позвольте вас поприветствовать
The MOH Russian Federation, I would like to welcome you and congratulate you on the 100th anniversary of the TB service in Uzbekistan and establishment of the Research Center of TB and Pulmonology of the Republic of Uzbekistan, and on the opening of such an important conference on relevant issues of TB science. And I hope that the conference will be constructive, and I wish you all the best and fruitful cooperation. And now I would like to switch to my presentation, which is on the achievements and prospects of the TB service of the Russian Federation. So, colleagues, as you can see here, we see the trends, downward trends in TB incidence and mortality in the Russian Federation. Yes, we have made good progress, and we reached the historical minimum, and even in the best Soviet years, we had higher rates for incidence and mortality, and that happened thanks to the fact that under the leadership of the MOH of the Russian Federation, our service managed to reach considerable success when decreasing the rates, including also support from the WHO, and you see how we are different the global trends. So this is a positive change, and thanks to our achievements in 2021, WHO excluded Russia from the list of high-burden TB countries, where it was for 20 years, and at the same time we do understand that we are still facing challenges, first of all due to drug-resistant TB and TB HIV. By the way, we have retained our position in the list of MDR TB burden countries and TB HIV burden countries, and we do understand what challenges we have to address in this regard. In this context, I would like to recall this statement by our distinguished academician, Hamenko. He was my mentor and the mentor of many doctors present in the room, and as for doctors in Uzbekistan, I am sure that you all remember it. So, in 1997, Alexander Grigorievich warned us that drug resistance is a serious threat to all our anti-TB interventions, and it's a considerable barrier to achieving the goals we have set before us, and we only started understanding back then that we were facing such a challenge as drug-resistant TB. And currently our country is a place where drug-resistant TB exists, but we also need to state that we carry out appropriate testing for DRTB patients, and
situation is way better compared to other provinces. At the same time, we report high among new and retreat, and this trend is increasing that among new cases. So a third of the patients is MDR TB cases. At the same time, we do understand that the absolute number of TB patients in the last 5 years demonstrated the stable downward trend, and the data for 2020 and the preliminary data for 2021 confirm this. While discussing TB HIV, which is the second biggest issue in our country, we would like to note that all TB cases receive HIV testing, and we have complete understanding of the number of patients positive for HIV. And among the new cases, one fourth of patients is patients with HIV. They are definitely managed using special protocols and they receive special attention. At the same time, this number of patients has not increased in recent years, and we have some slight downward trend. But at the same time, we can state that as for the number of such patients, well, their number has not changed considerably. Speaking about the new coronavirus infection, which has affected the globe and it's been with us for 3 years. We do understand the risks associated with this pandemic, and we definitely understood that there is an increasing rate of higher incidence and mortality, and that there will be more patients with severe forms of TB. And to keep the situation under control, to avoid increase in the main rates and to ensure full-fledged care delivery for our patients, our TB service, jointly with the Ministry of Health, has taken a number of measures to have TB under control, and definitely this is preventive screening examinations for risk groups, which we keep doing for all the population, but during the COVID times, we focused on risk groups. Definitely, this is availability of molecular genetic diagnostics and testing, and also telemedicine-based patient management and telemedical home-based support. And then a number of areas have considerably advanced in this area, and video-supported observation of therapies has become widely spread in those provinces, and during the COVID pandemic, that also helped us in terms of TB management, and the introduction of new technology, new regimens, and new tools was in progress during those years, and it all contributed to better control of the situation. And a couple of words about the national TB strategy in the Russian Federation. Well, it really pillars which were announced by the WHO: political support, definitely patient-centered approach to TB care we provide for our patients, to be control, and definitely attention to research and TB control. And speaking about political support, I like to highlight the following. Well, for at least 25 years, all TB programs have been financed by the government. Treatment and preventive examinations for our patients are fully free of charge, and availability of all drugs, including new expensive drugs, is 100%, and definitely social support is provided for our patients. Our patients keep their jobs during the TB treatment, and if they receive the disability status, then they receive disability pensions due to severe forms of the disease. So let me switch to the patient-centered approach to treatment. Here I have presented the key components we rely on. Definitely this is prevention, early detection of TB and drug-resistant TB, measures to ensure effective treatment, and measures to ensure adherence to treatment, video-supported treatment, social package, and other measures. And of course, departmental, interdepartmental programs on TB, HIV, co-infection control, and some words about early detection of TB. In our country, traditionally, we carry out screening for all the population for TB. For pediatric populations, this is skin test, and for adults, this is fluorography. And with the support of this very approach, we frequently detect patients at early stages of TB, and in many ways, these forms are not contagious, and definitely this is great relief for our service since it is way more effective and faster to treat such patients. And also, I'd like to highlight the role of a new screening test available for our children. Since introduction of innovative tests, so recombinant skin test, many issues of the pediatric populations have been addressed. So we stopped detecting false positives infected with MTB, and we focused on detection of truly contagious forms, including active TB. And then the detected cases became more meaningful, and actually we really advanced here, which enables us to have better control of TB in children. And special presentation today will be made on childhood TB, and dear Valentina Alexandrovna will make this presentation, so I will skip that, and I'd like to highlight the importance of introduction of the pediatric dry skin test and pediatric TB control. As for diagnosis of MDR-TB, this is a priority for our TB interventions since no treatment regimen, no prescription by a doctor can be effective without high-quality testing for MDR-TB. And as I said before, almost all patients at early stages of therapies prior to treatment are tested using molecular genetic tests and later on using culture, so we could have a complete picture of the susceptibility ranges and resistance to drugs, so we could really prescribe effective therapies. And for that, we have all the capacity. We use the technology which is used globally, and also Russian technology, which is equivalent, sometimes we are superior to foreign technology in terms of the number of drugs we test resistance to, namely Russian technology Synthol makes it possible to identify resistance to isoniazid, rifampicin, and fluoroquinolones, and it takes only 5 hours. And using the TB biochip, which is also manufactured in Russia, we can identify resistance to ethambutol and others. And that's how doctors have the tools to appropriately prescribe drugs. And while discussing treatment, we need to highlight that definitely etiotropic therapy is key to treatment of TB patients. And as I said before, this is case-specific based on drug resistance patterns in a specific patient, and at the same time we stick to traditional TB control approaches when, in addition to etiotropic therapy, pathogenetic therapy is prescribed as needed, as well as symptomatic therapy, and the therapy aimed to prevent or manage adverse reactions. And in challenging cases, endoscopic treatments are used, and if surgery is needed, then definitely we use surgeries as part of the comprehensive management of a TB case. And all our clinical uniform. They are part of the clinical recommendations and they are approved by the Ministry of Health of the Russian Federation. They are available for each and every doctor, and our protocols are updated regularly. The latest update occurred in 2022, and we plan their further updates since new data are coming on treatment of TB patients. At the same time, we need to highlight that genetic diversity of mycobacteria strains is great in our country, and actually we identified 49 variants of MTB with drug resistance, and there are various genetic families, classes, and in with different resistance patterns, and that's why we cannot provide the same treatment for all patients. And we have specific algorithms for prescriptions, and they rely on testing results, as I said before. So the first stage, this is molecular genetic testing, and then when we receive data on resistance, then we do culture, and possibly we adjust the therapy so the treatment could target a specific agent with specific susceptibility or resistance pattern. We take pride in the Federal Register of TB patients, which is integral to our practices and has been so for 5 years since 2017. And it's been in place, and we use it for monitoring of all TB patients in our country. So it relies on the principle where we register absolutely anything, and in fact, it helps us reach administrative and clinical decisions. Dear colleagues, TB control in the Russian Federation relies on the traditional structure of TB facilities. We have kept the network of TB dispensaries, hospitals, outpatient facilities, and that's really helpful in our operations. In addition, we have the same approaches to treatment, prevention, diagnostics, and we introduced present-day innovative techniques, and we also receive state support, and it all enabled us to reach considerable success and to improve the epidemiological situation with TB in previous years. At the same time, new coronavirus infection changed the situation, and we still have the areas in need of further analysis and research. This is prevention, diagnostics, and treatment. And of course, our efforts in research aim to improve test kits, develop new diagnostic tools for active and latent TB infection, and definitely we are working to assess new treatment regimens, shorter regimens, and we try to select the most effective regimens for hard to manage patients with resistance, multiple resistance, and TB, HIV. And here I'd like to focus on some of the developments which have been in place and being tested clinically. So at stage 3 of clinical trials is the development of the Russian Gamaleya Institute, GAM-TB vac vaccine, and it has demonstrated good results at the preclinical phase and at the second clinical phase, and it enhances the existing BCG vaccination, and it prevents the disease in adults. And the trial is in progress, and I hope that soon we will assess the results and the vaccine will become available for practitioners. While discussing the genetic diversity of MTB strains, I would like to highlight that in research it is essential to find mutations, drug-resistant mutations, and our center does full whole genomic sequencing to find those new mutations, and this is essential to assess the prognosis, to identify the markers of drug resistance, and to develop the new test kits for new clinical solutions for practitioners.
Our efforts to develop chemotherapy regimens continue, and we deeply and thoroughly approach this topic. We explore risks of emergence and development of drug resistance, and we explore the importance and significance of a certain drug in a treatment regimen. We work on the duration of the treatment. We look at remote or distant results and see if there's a likelihood of development of resistance depending on used treatment regimens and sensitivity of mycobacteria to specific drugs. This helps us to develop new treatment regimens, and efforts and research in this area are ongoing. There are 3 treatment regimens for 3 categories of patients, and they're being studied: the short-term and 9-month regimens. And once research is finalized, I believe that we will have new methodologies for treatment of our patients, especially with those who have drug resistance. There are important research areas that search for markers of active and latent tuberculosis. There's a significant progress. We're looking for these markers, and that means we're developing new test kits for differential diagnostics for active and latent tuberculosis infection. We're also working on alternative drug development, which would act on mycobacteria with any drug resistance. So it's based on a mycobacteriophage, and clinical trials are showing promising results. In the very near future, we'll have a drug that would allow us to fight any drug resistance. In conclusion, I would like to point out that currently the Russian industry and Russian researchers are working diligently on import substitution. So we developed a new cartridge-based test system to replace the well-known gene expert that would allow for quick detection of drug resistance, not to 1 but to even 3 drugs that are first-line and second-line drugs. In addition to that, there are developments for mycobacteria tuberculosis typing and a test system for detection of drug resistance of non-tuberculosis mycobacteria. This is ready to be issued in practical healthcare, which will significantly reduce the financial burden of our TB control and other clinical services. In conclusion, I would like to say a few words about our National Medical Research Center of Pulmonology and Infectious Diseases, which I am in charge of. Here we have the main spectrum or focus areas of research. You see that we are engaged in fundamental research, clinical and operational research in all highly relevant areas in TB care in our country. We have the clinical basis also for surgical treatment of pulmonary TB, bone and joint TB. We have a separate clinic that treats patients who have TB and HIV co-infection, and also other pathologies of respiratory organs. Dear colleagues, thank you very much for the invitation to this important conference. Allow me to once again congratulate you on the anniversaries and wish you the best. Thank you. Thank you so much, Irina Anatolievna. I was asking my assistants if Irina Anatolievna is online. No, she didn't connect, but I think that Valentina Alexandrovna and her other colleagues from Russia will convey our heartfelt gratitude to Irina Vasilieva and our TB care service to thrive wherever it is. So we're all moving forward. Some are more advanced than others, less advanced, but we're openly sharing all our endeavors, developments, and methodologies. And I know, I'm confident that both Irina, Anatolyevna, Tatjana Alkeshevich, and Valentina, some of those who are responsible for TB care in the Russian Federation, always find it a joy to share what they have. And likewise, we are ready to share continue research cooperation. So new technologies and innovations could be the grounds for our joint research. Presentation and is about the current issues of tuberculosis in children and adolescents. I'd like to introduce you to Valentina Aksionova, Chief Pediatric Physiatrician of the Ministry of Health and Social Development of Russia. And I'm thankful to our Farm Standard company, which for many years has been helping us to see personally Valentina Alexandrovna. And I think that this will be an interesting presentation. And Valentina Alexandrovna, please share your innovations. And thank you in advance. Thank you so much for this introduction, my esteemed Presidium, colleagues, dear friends. And the recent 40 years, myself personally, I've been working with all our former Soviet republics, and we continue working in this manner. On the WHO, there's a working group that was established on TB in children and adolescents about 15 years ago, and that's the first group of this kind in history. So all of us annually meet, communicate, and discuss childhood TB-related issues. And the World Health Organization publishes documents, and they take into account our physiopediatric opinion. I think that we also determine areas of work in the future, and that we will work together because Mycobacterium does not recognize any borders. And how can we speak about TB in one isolated country? Well, children are not one isolated country. If we're saying that there's no TB, that first of all, we need to take a look at the problem of childhood TB. And this is more important in Eastern countries. I know that in Uzbekistan, 30% of the population are children. That is excellent on the one hand, but we should never forget that they are infected by adults. And it's always important to feel when you do your work on TB. Now let me touch upon issues of childhood TB. I will reiterate everything that I will tell you that relates to WHO. All these words have been developed by us. We are no exception. It's not that somebody tells us to do something. No, on the other hand, we're speaking about what needs to be done, and based on that, they developed the World Health Organization updated the areas of policy relating to TB in children. We all remember there was a period when it was thought that the main thing is to treat and cure an adult, that's when we will no longer have TB. But the World Health Organization reconsidered the approaches. Now, prevention and screening and diagnostics of TB has become a priority. These are the key problems on childhood TB. That's vaccination, early diagnostics, TB and HIV infection, drug-resistant TB, and drug formulations for children, and short treatment regimen and courses. They are relevant both for adults and children. In the recent 10 years, Russia published quite a large number of legal and regulatory documents at the level of the government. I'm not going to list all of them, and also at the level of medical community. Clinical recommendations in Russia equal the order or prikaz of the Ministry of Health that are binding, legally binding, and we developed clinical recommendations for these documents. And in the recent decade, more than 10 of them, of such documents, were developed, and their tabletop guides for TB pediatrician. There will be a school organized for TB in children and adolescents. There are different specialists who will speak about each and every problem relating to this field, and I will be brief. And I will try to stick to 20 minutes. So recommendations of WHO for TB prevention. So what has been done? Vaccine prevention, TB. The BCG and BCGM vaccines have been enhanced. We have cancer vaccination of adolescents. Now we're thinking about cancer vaccination at the age of 7. And it's important to have initial vaccination. Vaccination with BCGM, it is allowed to vaccinate children born to children with HIV infection. We have also conducted monitoring of post-vaccine complications in the Russian Federation, and that was the main reason why no vaccination, people voted against vaccination. And with also clinical recommendations on vaccine prevention of TB in children. We know that complications as a result of all kinds of vaccine, 90% of cases are due to BCG vaccine. The enhanced vaccine, here we're showing the data of research stage where we increase number of life. So now we can immunize all children with BCGM. Now, this is the chart of complications. Now, they used to exceed the incidence level. Now we have single cases only of complications in children. Either this is due to violations of techniques, or that would be fixed with further training, or wrong time for vaccination chosen by pediatricians. Coverage with vaccination has increased. It's still insufficient at birth because parents reject vaccination, but by the age of 1 year of age, it's 75%. This is this was information about vaccination. The next part of prevention is screening, and we need to prioritize and emphasize. We need to prioritize measures considering specifics of childhood bodies. And Irina Antonovna spoke about immunodiagnostics in children. Yes, that's an important part of our work. We understand this and recognize and accept this, and just as WHO does, thinks that screenings are important. So systematic screening for TB is one of the interventions that can help achieve global goal in treatment of 40 million people from TB. And then we need to remember this and know this. Russia has been working this for a long time. When there was no alternative to tuberculosis diagnostics, we conducted research. These are large research in Primorsky region. There's a lot of TB, and they cannot revaccinate them by in the age of 7. They have positive test results. Is it because of infection or allergy? That's a question. New tests came up, the in vitro tests and in vivo tests. One of them, the in vivo test, is the skin test or an allergen tuberculosis recombinant test. In Russia, we use all kinds of tests, and they are allowed for use in under specific conditions. So before we introduced a new in vivo allergen, it was the first one, the Russian one. Now we have 3 tests, and we're developing newer tests. Now everyone is coming to an opinion that in vivo test is more important and relevant. For Russia, it was important because it was focused in Russian and simpler for us. So practically, it is performed the same way as tuberculin diagnostics, but we can see the sensitivity that is identical to the one of tuberculin. The specificity exceeds it by several times, and we can remove from false positives here. How did Russia introduce this? As first at the level of the TB care service in dispensaries. Then we introduced it. We examined pharmacoeconomic effectiveness. We understand that it's more cost effective. And we conduct different studies in the regions, and only after that the order was passed. So we have to have it before the age of 7 because our vaccination still remains. And once there's no longer any revaccination, we can raise the issue about canceling tuberculin diagnostics and perform it at an earlier age. Now it's the same way with a positive not-to test results. The child is referred to a dispensary. The first thing they do there is a dye-skin test and then decide on further assessment of the child. All children older than 8 years of age are undergo immune diagnostics using in vivo or in vitro tests. Adolescents. At school, you will be told that adolescents can tested both as adults and as children. And the methods vary from region to region. There are documents published on immunodiagnostics. We need to. That was complex. To overcome or to change the paradigm in the TB doctor community is difficult. We're very conservative. It was believed that you have to vaccinate or revaccinate before the age of 30, then it should be done. I keep proving everyone that there is no need for vaccination, but doctors seem to be confused. Only the publication of WHO, which we as pediatricians contributed into, showed that one primary revaccination is sufficient as long as the coverage is enough. Preventive screening, as Irina Antoline said, and I will repeat, is quite high, 70%, but that's because of children, especially adolescents. 90% of adolescents are undergo preventive screening. So, and the detection rate also, smaller forms of TB only using computer tomography instead of, they are not seen on X-ray images or, so, and that facilitates the treatment. So this is the chart showing the reduction in incident in children and especially adolescents. And it used to be higher in adolescents. So, and it decreased in all age groups. Now, this is the experience of our regions. We have a representative of pediatrics of Tatarstan, and he will tell you what happens when you change the method for adolescents and to use. So if fluorography, for example, well, it's a good method, but it's more meant for adults. But fluorography detects TB. Well, in immunodiagnostics, only identify the risk group with LTBI. This is what we're actually striving for. And all the previous speakers were speaking about that as well. Now, the first pilot showed that yes, there is a reduction in children and a reduction in adolescents and in young adults also. That's the most useful age from. And there's a rapid decrease or sharp decrease in TB these groups. So if children are found to have LTBA and receive effective treatment, then they will not develop the disease.
Children almost never die of TB, so we are ensuring future healthy generation. This is confirmed by the fact that our screening was recognized as the best screening globally. This is confirmed by WHO. And last year, the journal Lancet, it was recognized as one of the methods for immune diagnostics. And the last point is that this year, WHO included it in its module for TB diagnosis in children. So we have all the documents that make it possible to switch to this technology. So as for prevention and diagnosis, we have mentioned that, but now let me focus on treatment of children. Practices in Russia. So we have few pediatric cases in Russia. We have not more than 1,500 children, some 700 adolescents. So you see the red and the yellow parts. Yellow is residual changes. So, the major part is preventive treatment, and we have to focus on this group to do preventive therapies, provide prevention. So as for active TB, we share the same problem. So we need new drugs, shorter treatment regimens, monitoring of adverse events, and case-specific regimens. What's done here is, and before we discuss it, we have to recognize that actually TB in children is different compared to TB in adults. Mostly lymph nodes are affected and almost no bacteria are excreted. And as for susceptibility patterns, they are difficult to identify, but given the increasing resistance rates, I guess this is relevant to all our eastern provinces. And as Irina Anatolievna has mentioned, if we need to ensure complete detection of resistance. And here it shows that every third child has resistance. And if we understand that children get infected from adults, so these are the susceptibility rates for children from among contacts. Well, it fully matches the pattern in adults, and they can anyway contract resistant TB. And also WHO states that children with DSTB or with DRTB. So this is information from the working group on TB, and all countries are included from our region in this group. So new drugs are being developed, but actually it's more challenging in children, and that's the latest module, which relies on our views. And the first point is that we supported it. It was really difficult to implement, and now it is well recognized that the priority should be combined drugs. So if a child has weight less than 25 kilos, which is every second child under 7 or 8 years, then we cannot split the pill. So combined drugs need to be administered where it is so easy to administer. And in fact, a number of combined pills being developed in Russia. As for treatment of DRTB, drugs are being developed, and definitely it's a problem. We do research. The laminate has become available, bedaquiline, and bedaquiline, while Russia participated in introduction of bedaquiline. There was not only in Russia, there was the global study to identify the effective doses and the rationale for administration of bedaquiline in children, and now it is introduced for children and it's allowed for children in Russia as well. The next point is drug susceptible to be. Here we can see that everyone recommends that, as well as WHO. The shorter regimens are recommended and we provide them, we participated in them. Now we are close to the end of the clinical trial, and so if you don't have evidence, you cannot introduce it. And now we are coming to its end, and next year the classifier will change and officially shorter regimens will be used. Regimen 1 and 3, so levofloxacin is allowed. We need to know it, and it's all perfect, and that's why documents from WHO, yeah, I keep repeating that. So these documents are ours. There is no need to check them. We have processed them, not Russia, but our working group, and it includes all countries globally and specifically countries from European region. We have Russian speaking and English speaking regions, and we are all aware of this. Ask your TB doctors. They also participate in those discussions, but definitely the key priority is preventive treatment, and the major problems in Russia include what TB drugs and regimens are effective against latent infection, and definitely we need to take into account tolerance and what studies are in progress. Well, as for latent infection treatment, if positive, only if IGRA test is positive. If Monto is positive, the rest is not done. There is no sense in doing that. And in fact, our data for the last 10 years suggests that every second child receiving preventive therapy, well, that was not justified. Why? Because two tests didn't give reliable information, and parents started rejecting that. And I guess you also have this concept. So when parents discarded isoniazid, and you could find it on the way from the pediatric dispensary. And if it's a contact, the trend is different. I will tell you later. And definitely, first of all, you need to treat children at risk. New drugs have emerged for immune deficiency status and for transplantation of organs and for cancer. Well, actually, all these conditions suggest risk groups, and the studies suggest that isoniazid and rifapentine are the most effective. Well, and they are easier to administer. Parents tend to agree. And if it's a risk group child, then such drugs are more preferable. And WHO and the company, the manufacturer, they indicated that this is allowed for children once or twice a week. Well, definitely it's way better. And let me discuss immunity related issues. If you remember, some 7 years ago, if a child is contact of MDR-HB, then treatment and prevention are better to be avoided. Well, at least if the child gets sick, then you will have something to treat the child with, and then that necessitated revision of drug resistance models, and we decided that we had to take into account the following. We had to have the IGRA test-based confirmation of the TB, and we tested contacts, and you see we had quite a few of those, and we did monitoring
of all sick children, and we sampled MDR-TB contacts, and it happens so that if it's not an MDR-TB case, then the incidence is 2 per 1,000 contacts. If it's an MDR-TB case, then it's 13 per 1,000 contacts. And if it is an MDR-TB case on chemo prevention, then the incidence is equally high. So we had to change the approach as clinical recommendations have been issued, and they suggest that the priority area for risk groups and in children preference should be given to soluble combination drugs, and the preventive therapy should prioritize modern present-day regimens, and especially for preschool age children, MDR-TB contacts IgR rate is positive. So actually, a complete TB testing should be provided, and then treatment should be given the source of infection. To sum it up, I can say that the key indicators for effective pediatric TB control include the 4 steps towards success, from early detection to prevention of disease. What needs to be done? High quality vaccination at birth, early detection of LTBI, appropriate preventive therapy, treatment without residual changes if a child gets sick, and then sanitary epidemiological monitoring, which is needed, first of all, to isolate the child from that pocket of infection. Thank you so very much. I wish all of us every success, and I do hope that we will work all together in the future. Valentina Alexandrovna, thank you so very much for this information, because, well, your monographs, your articles were training materials for us. And in our country, we haven't had booster doses revaccination since 2009. I'm happy for you. Yes, and we haven't reported any growing rates. Actually, we relied on your study because you proved that children at the age of 10 still have effects of the vaccine given at birth. And you are perfectly right. Children get infected from adults, and to decrease the TB burden in our country as well, which is happening actually in our countries, suggests that the real need for a vaccination is missing. And you have correctly mentioned that if we consider complications of the vaccination and the incidence, well, we better consider it carefully. And so we are the nation with the motto for the healthy generation, and like in your country, we preserve pediatric sanatoria. And when Farida Turdiyevna Sadikova, you know her well, worked in our service, we had research, and its findings were reported in London at this session of WHO Regional Office for Europe in 2012, and since 2011 at sessions of the European Group Against TB at Wolfhase, I kept asking how we can prevent TB in children in families with MDR-TB. If you only suggest rifampicin and isoniazid, and no one could answer that question, and we followed a different pathways. So we started checking immune status in those children, like you mentioned, and in children with immune deficiency. We tried to improve their immune status. So we placed them in sanatoria to improve the immune protection of children so they could resist the infection. Definitely against the background of chemo prevention. So we keep sharing our developments, because in fact, we do not see higher incidence in children and adolescents. And for you, we also can be another point, suggesting that in the country, which since 2009 has no booster doses, there is no growing trends. And we will keep on working together, and we are aware that WHO always relies on evidence obtained from multiple studies, and I am sure that extensive experience accumulated in our countries will be offered for the WHO, so it could serve as the basis for new recommendations they will issue. Thank you so very much again. The next presentation is importance of expert TB and diagnosis of TB and PHC network and provision of medical and social aid in TB patients in the Republic of Kazakhstan. Dr. Raja Parkulova is invited. She is the head of Department of Treatment of Susceptible TB, TB Center of Kazakhstan. Please, dear Nargiza Nusratovna, colleagues, allow me to welcome you on behalf of the National TB and Pulmonology Center of the Republic of Kazakhstan, and I would like to congratulate you on the anniversary of your center. And I would like to make a presentation on the area of importance of gene expert and TB diagnosis in PHC network and providing medical and social care to TB patients in Kazakhstan. The Republic of Kazakhstan is a sovereign country in Central Asia. It borders on 5 countries. It has 17 administrative units of the first level. So we have 16 provinces and 3 cities of republican importance, and also we have 218 administrative units on the second level, 164 districts and provinces, 38 cities of the provincial subordination. Even though we have 16 districts and cities of republican subordination, and overall in Kazakhstan we have 89 cities, 29 villages and human settlements, and 6,293 villages. So the total area is 2,724.9 thousand square kilometers, and the country ranks 9th globally in terms of its area. Why I'm saying this is because the structure of the TB service, which is represented by the National TB and Pulmonology Center and provincial TB centers and PHC facilities, so it is represented nationwide. And currently, the equipment is available for rapid diagnosis in all local TB facilities and laboratories at the district level. So starting 2008, we have introduced in our country rapid diagnostics using BACTEC. We have 17 BACTEC, and starting 2011, we have had hind tests, and no, BACTEC 26 and hind test 17, I apologize. And starting 2013, the country has got gene experts of them, so 148 of them, 20 are XDR TB machines, and use of the present-day molecular techniques make it possible to provide appropriate therapies to reach quite high effectiveness of treatment and to decrease cross-contamination, cross-infection among patients. And the new algorithm for bacteriology testing for patients has been developed in line with the recent WHO recommendations. And starting 2012, the National Reference Laboratory, well, we received the international quality assurance certificate from the supranational laboratory, unique and Gauting, and actually we carry out a QA for all 20 laboratories in the country, and whole genome sequencing is being introduced. So as for patient-centered approaches, year in, year out, we are expanding those patient-centered approach using hospital treatment replacing approaches, so home-based treatment, video-supported treatment, as well as when treating socially vulnerable groups to prevent treatment interruption, we actually engage NGOs and social services.
The standard of outpatient treatment is 55%, but beginning in 2020, this percentage has been higher, was 71.2, and in 2021 was 72.5%. I mentioned earlier, if we're working with a socially vulnerable group, then we partner with civil societies. We have 7 NGOs. I'd like to go back. I apologize, I'm a bit worried, nervous. Okay. Here for the first time. Okay, now we're going back. Okay, now I learned how to write. So in our country, there are 7 NGOs in 4 regions of Kazakhstan. They work based on government and social order, and the 4 NGOs work on the Global Fund. The treatment success of TB in Kazakhstan. Beginning in 1998, the government of the country has been allocating budget funds to purchase TB drugs. And all patients with sensitive and resistant forms of TB are ensured adequate treatment. In 2016, a non-government organization, Partners for Health of Harvard Medical School, under NTB project, Kazakhstan, initiated the use of new TB drugs for treatment of MDR and XDR TB, bedaquiline, and delamanid, linezolid, and clofazimine. Now, treatment regimens for M and XDR TB were revised to individualized and shortened regimens, and we also included new and reprofiled drugs. The clinical guidelines for treatment of M and XDR TB were revised and updated. In 2018, under the pilot project of Global Fund, we introduced a shortened 9 to 11-month treatment of our MDR TB instead of the 20 and 24 months of treatment, the older regimen. Beginning in 2019, our country started procuring new and reprofiled drugs through GDF at concessional price, using the state budget funds. And Kazakhstan also introduced WHO recommended non-injectable forms to ensure adherence to treatment and improve treatment success. It is important to provide social support to them. The treatment success in 2020 was 82.2%. In 2021, close to part of MDR TB. There was a decrease of 2% in this cohort. As for susceptible TB with MTB plus, while here we achieved the WHO standard in 2020, it was 87.8%, and in 2021 it was 85.9%. That's thanks to social support. So, and this is funded by the state or provincial governments. So Kazakhstan allocates money to this. That in 2020 was 1.7 billion tenge. In 2021 was 1.8 billion tenge. the goal is at least 3%. The target is at least 3%. Now in 2020, it was 4.2%, and in 2021 was 5%. Thanks to the listed activities, treatment effectiveness in Kazakhstan is the highest in new cases of TB, drug-sensitive TB. Next slide. During COVID-19 pandemic, infection control involved, first of all, TB control organization because they meet infection control requirements of relevant resources. At PHC healthcare facilities, we introduced a changed algorithm for diagnostics of TB when COVID-19 is suspected. So international partners channeled funds, that's global funding, USAID, to counteract COVID-19 and TB. And cartridges were purchased to do the testing of COVID-19 and also to purchase PPEs. Thanks to Gene Expert MTB-RIF, we have improved detection of TB cases, especially generalized TB. In our country, beginning in 2019, we used Gene Expert to detect. Well, first of all, we tested about 40,000 people, of which we detected 5,011 patients. That's 12.2%. In 2020, there were fewer people who were tested, and 11.5% were detected as cases. In 2021, the coverage with Gene Expert is 98.5%. So the number of tested people increased. It was 7,958, and we detected 7,090 patients. That's 10%, and the specific weight of generalized TB in the population in the recent 5 years was 30.6%, and in 2021 it's 37.3%. So it's 1% in the lower bar. Now I'd like to speak about key epidemiological indicators of tuberculosis. The incidence rate. In recent years, the country has been noting positive changes in the epidemiological situation relating to TB. This slide shows data in the recent 7 years, over the recent 7 years, that the incidence of TB incidence decreased 1.8 times, mortality is 2.8 times, childhood illnesses 2 times. And the overall group of active TB cases also decreases. It used to be 21, almost 22,000 in 2014, and now it's 10,186 in 2021. There's significant improvement of all epidemiological indicators relating to TB, thanks to political commitment on all levels, and also introduction of the newest techniques or technology for detection and treatment of TB, and also uninterrupted provision of TB drugs and active collaboration with international partners. I'd like to also speak about interagency interaction. Here we're showing epidemiological indicators. Here we interact with the penitentiary system. So TB care is provided to prisoners in 3 TB care facilities and 18 investigation pre-detention facilities. So the treatment is provided both to prisoners and also ex-prisoners. There are bacteriological microscopy and culture tests and DSTs The DST is done at laboratories of TB facilities outside prisons, based on interagency memorandum with the penitentiary system. Infection control has been in action since 2010 in the penitentiary system. Also, there's a mechanism of handing over ex-prisoners into the civil sector. Once they're released, TB patients receive assistance from non-government organizations, and mortality in incidents has significantly decreased within the penitentiary system. Here you can see all the figures relating diagnostics and treatment within the penitentiary system, and all this is synchronized with the civil sector and coverage with gene expert MTB RIF. Reached its standard. The availability of a gene expert now is in 2021 was 95.2% in the penitentiary system. We are also but they're also provided with new TB drugs. It's 100%. As for individualized treatment regimens, the drugs are available. All of them, 100% of them are available for this as well. We have 70% patients registered for such treatment, and as of now, the 4 are wanted. We have strategic development areas and further implementation of NTB strategy in Pakistan, also improvements in quality and accessibility of pulmonological care and thoracic surgery. First of all, we are working to improve quality of implementing modern effective technology for diagnostics, treatment, and of the TB and DRTB. And also we're working to strengthen prevention. We're also improving quality and accessibility of pulmonological care to the population of Kazakhstan, and modern methods of diagnostic and treatment on bronchial and pulmonary diseases. We're also strengthening systems for infection control and monitoring assessment of tuberculosis and bronchial and respiratory diseases. We're also developing our thoracic surgery methods and ensuring access to these surgeries. Now we have targets for 2025. So the NTB indicators for 2020 have been fulfilled. All 2020 indicators are shown here. This is about reducing incidence and reducing prevalence. And then our further goal until 2035 is to meet the targets of the NTB program. Thank you very much for your attention. That's all I have. Thank you very much, Doctor. I would like to wish the entire team in Kazakhstan, first of all, represented by Malik Moldabekovich, who was unable to come, unfortunately. Would like to wish your entire team success. You're our closest neighbors in the north, so the epidemiological situation, as we all say, recognizes no borders and depends on migration-related processes. But we will address all these issues as well. And the last presentation in this plenary session, but last but not least, it was about epidemiological situation of tuberculosis in the Kyrgyz Republic. Dr. Anova, Deputy Director of the National Center for Phthisiology of the Kyrgyz Republic. Good morning, dear colleagues and participants. I'd like to share information and important aspects, as well as data regarding epidemiological situation relating to TB in the Kyrgyz Republic. My presentation includes the description of the organigram of the TB service in Kyrgyzstan, the policy of Kyrgyzstan controlling TB, information about epidemiological situation regarding TB in Kyrgyzstan, also influence of COVID-19, achievements and results of the program, and next steps and challenges. Our country borders Kazakhstan, Uzbekistan, China, and Tajikistan. Population size, as recently announced, was 7 million, and the area is 200,000 square kilometers. The TB care service in Kyrgyzstan is headed by the Ministry of Health, the National Center for Phthisiatrics under the Ministry of Health. There are Republican TB hospitals, as well as rehabilitation centers. There are 5 of them. We have provincial and city centers, TB control centers in each of the provinces, and in the city of Bishkek, we have TB hospitals. And within the penitentiary system, there's 1 hospital. On PHC level, there are 63 TB rooms. We've implemented 5 TB programs, the 3 WHO strategies: DOT strategy, Stop TB strategy, and NTB strategy. Kyrgyzstan is one of 30 countries in the world with the highest level of drug-resistant TB, as well as one of 18 high-priority countries in the WHO European region. I already said that we've implemented 5 programs by now. This year, another TB program, or TB program, TB6 was developed and submitted for consideration of the government, and also a law on protection of the population from TB was adopted. Under TB6, there are priority areas and key measures. And the program is designed for 5 years, and it includes priority areas such as strengthening health and reduction of risk of TB disease, detection and diagnostics of TB, treatment of TB, integrated system for TB care delivery, and also monitoring and evaluation of the program. So what is the dynamics relating to incidence and mortality for TB? In our region, it's a bit higher than in other regions. And we are showing data for the recent 10 years. In 2011, there were 100 cases per 100,000 population. Before COVID pandemic, we were able to achieve a decline in this these incidents by 79 almost cases. In COVID, due to COVID, the detection rate was 32.2%, and the Ministry of Health took a lot of measures, but these measures produced very few results, and the increase was only by 5%, and the incidence rate was almost 59 cases per 100,000. And mortality was expected to grow because patients were elsewhere. Due to COVID, there was restriction on movement and travel, and TB hospitals were reprofiled into other hospitals, and TB doctors were actively involved into COVID control, and we expected our patients to be dying somewhere, but the mortality, as you can see, remained the same. In 2019, equal 3.9 cases. In 2021, it's almost the same, 3.8. So, what is the incidence? So the incidence is shown on this slide. Estimates for 100,000. or to 205%, but the actual notified number of cases is of 53, and the 20 July it was almost 59. There's also, of course, under detection, and Ministry of Health and NTP in Kyrgyzstan are doing a lot to increase detection rate. I'll speak about them later. What is the situation for drug-resistant TB? The proportion of DRTB in new cases. So the highest was 27% in 2016. In 2021, we see a reduction to 23.8. In retreated cases, that was 68%.
Well, as I said before, a lot of measures were taken and we managed to decrease it to 46%. As for the confirmed cases of TB, their number in the last 11 years. Well, say in 2010, we registered 141 cases, and the coverage with treatment was some 78%. And in 2019, you see that rate increased to 1,067 cases, and the coverage was higher, 90%. And even during the COVID pandemic, although the number of reported cases went down, but the treatment coverage was increased even to 94%. We managed to do this, and in 2021, as you can see, we still couldn't get back to the previous rate, so we have lower DRTB detection rate, 870 cases, based on the reports for the previous year. So as for treatment effectiveness, so DSTB, the treatment success rate is 84%, and well, within the recommended range by WHO, but we would like to highlight here, we have a lot of patients who are detected and classified as DRTB, and I'd like to say that the country is active in introduction of new and reprofiled drugs, and implementation rates have shown that we now have way better results. If in 2017 it's 5.8, in 2018 it's 62, and in 2019, within 1 year, we managed to improve it by 10% to 72% almost. And say in 2013, it was some 15%, as you can see, and how COVID-19 affected the detection rates. We have two curves here. Yellow is TB. So in the first quarter, when it was only the beginning of the COVID-19 pandemic, we had that many cases, and then in July, we call it Black July, it went down by 50%, this very rate. And next, you see 39,000 cases of COVID, and definitely it had its effects on the TB case detection rates. As I said before, TB doctors were involved in anti-COVID activities. TB doctors got sick, they couldn't work, and we also had a lot of other problems, and as you can see, within 1 year it went down. We had several COVID waves, and the case detection rate decreased, TB notification rate. And I'd like to focus on the fact that case detection rate in the first quarter of 2020 was 1,839, and we failed to reach that rate because now it's 1,287 only. And this slide shows the breakdown by province, like in which provinces we have the most prominent reduction. And surprisingly, in the Isikul area, where we have our resorts, it was 40%, and in Batken province it was 16%, and in fact in others it is more or less evenly distributed, 30% or almost 30%. And the key operations of the National TB program. As for prevention, improved detection and diagnosis of TB, we, like in other countries, introduced a rapid technique like expert LPA for second-line drugs. So the country has 24 platforms of expert. And as for in 2017, we introduced Pine test for second-line drugs, and quantiferon has demonstrated good results. I can say that we actually do whole genome sequencing. DST is done for new drugs, bedaquiline and delamanid, and reprofiled drugs, and we have reported cases resistant to those drugs because these drugs have been used since 2017. I'm not saying we have too many resistant cases, but anyways, we reported them. The new diagnostic algorithm using molecular genetic technique expert is used nationwide, and also the system for transportation of biological materials and first-line and TB drugs is well established in the country, so to district level and then back from district level to tertiary level. So transportation of samples yesterday in our session, we discussed how it is done and how it is financed. That transportation model was developed in 2017 and demonstrated effectiveness and as a pilot. And then since 2019, the biomaterials and TB drugs transportation system was expanded nationwide, and transportation is outsourced. And the source of financing for this transportation system for 2 provinces is state budget. As for other provinces, so far this is covered by the Global Fund, but later the plan is to expand the coverage with the state funds. And this slide shows TB preventive therapy for children. So the clinical guidelines have just been prepared this year and they are being approved. And definitely previously we asked tuberculin diagnosis and treatment with isoniazid. You see the coverage more than 80%. And in 2019, the plan was 91%, but the actual well, we failed to reach the target because the tuberculin price increased, and when we applied for it, we managed to get it via bidding, but the actual implementation rate was 71%, and then we managed to improve it to 93%. As for more effective TB treatment, definitely treatment is in line with the latest WHO recommendations. So we implement and use new TB drugs like pretamanid, bedaquiline, delamanid, and reprofiled drugs. We introduce shorter and individualized treatment regimens using new TB drugs, and I'd like to share the results of the new treatment regimen BPAL, and actually now it's introduced in the program, and the success rate is 86% for the first cohort. As for other drugs, as for case-specific regimens, well, definitely we have very high rates and very good results were obtained from XDR-TB patients previously before introduction. The treatment success was 33%. Even there was downward trend, but with new drugs, we managed to improve it up to 65%. And we do active monitoring of adverse events of TB drugs. We report adverse events, and this year we managed to develop clinical guidelines for pharmacovigilance and for adverse events monitoring. Yeah, the whole country is following these guidelines, and we build the capacity of provincial concilium for DRTB. We decentralized it, and actually any province can participate in video conferences, and if we have challenging cases, then they can join the central concilium. As for patient-centered treatment model, the resolution of the government approved the action plan to optimize TB care in Kyrgyz Republic for 10 years, and this document provides for closing hospitals. So if previously we had 21 hospitals, now we have 15. And as for the total number of beds, it's 1,855. So we closed more than 1,000 beds. And last December, the order of the Ministry of Health was issued. And this order suggests that 450 beds had to be closed. So 7 hospitals were closed. And patient-centered approach is used in TB care delivery. In pilot provinces, we introduced the TB case management system. And the PHC financing mechanism has been developed and is being piloted. So this is funding for successful outcomes, and as discussed yesterday, the new payment system was introduced for TB hospitals. All TB hospitals have been covered, so this is program-based support. The software treated cases has been introduced in the state health insurance system, and it's introduced in all facilities. So how this patient-centered model is implemented in treatment, actually at the PHC level, the TB case management approach has been developed and is introduced. The objective is to improve treatment outcomes and to decrease the risk of TB transmission. So social assistants are engaged in the treatment process, and video-supported treatment is introduced. The treatment adherence is assessed and monitored. The psychological social support is provided throughout the treatment period. Clinical monitoring is done, as well as monitoring of adverse events. This is done even at the PHC level. Who is active here? The chart shows this. So the objective is to pay to PHC for TB services. Well, definitely the major percentage of this payment is received by family nurse, because most of the interventions is done starting with detection by nurses, and then after hospital treatment, she does the monitoring and has control of the treatment. So more than 50% goes to a nurse. And more specifically, as for case-based financing for DSTB, this is some $250. And as for the RTB cases, if the outcome is treatment completed or cured, then it's 24,000 soms, which is twice as much. And let me note once again, so half of that is received by a nurse. As for TB information system, so electronic medical record for TB hospitals has been developed, as well as the software for laboratory data management, and TB information system is integrated in other government electronic systems, and using the interagency electronic interaction system Tunduk. Now it takes less time to share data, and access is improved to government services for the population. So a person can sit in front of his computer, the red flag pops up, and it means that the laboratory results are ready, and results can be obtained by doctor in 2 hours if it is gene expert. And other tests, definitely, be communicated to the doctor's computer, and so distribution of drugs can be managed digitally as well, and the unified patient ID is used to avoid duplication. Such systems have been introduced in 20 TB hospitals, and now we have introduced it in 92 laboratories, 72 PHC, 20 TB hospitals, and they all are provided with comprehensive computer equipment and infrastructure. So electronic TB register database was introduced. And this is the chart showing the e-health system. It includes pharmacy of hospitals and users. Users can see what drugs are available and prescribe pathogenic therapies, and TB drugs are always available. And also we have the laboratory MIS, as shown here. It's available in 92 laboratories, more than 551 users, more than 1 million records. Electronic TB register is available. So TB01 form, TB01 form for drug-resistant cases. So we have the website of the National TB Center, and we have our accounts in social media, and the mobile application One Impact. This application enables all stakeholders, not only patients and contacts, but and other people who want to know more about TB if their close ones are in the hospital. So all this information is available in the application, and we are developing it, and we will keep on doing so. And what are the priority interventions as plans, activities to implement the TB6 program? Training for health professionals at the PHC level, the TB service, introduction of new technology, diagnosis, new treatment regimens. So we have received a lot of new information, and we have to conduct trainings frequently. Expanded transition to state financing for TB control interventions. As in other countries, first-line drugs are procured fully starting 2016, and so 30% of second-line drugs are procured from the state budget as well. But we have another problem. It's not possible to procure other drugs in the country because we don't have the companies that can participate in that. That's why we are discussing application to GDF, so we could apply the second-line drugs via GDF with possible expansion of that range. Then development of digital technology and TB service. We also carry out regular awareness raising activities with target messages for various target groups among the people, and also the national TB program will introduce new preventive treatment regimens, and of course 5 new regimens, and all pediatricians and other stakeholders are very happy about the new shorter regimens, which take 1 to 3 months, and there are issues about chemical prevention for endurance B contacts, and we are cautious about that. And I guess in the pilot district we will introduce that since contacts come to doctors and they ask as well, I don't want to wait when disease develops, and I don't want to see my children sick.
We need to provide the assistance to them. Possibly the introduction of such treatment next year. It's not for next year, incrementally. So we're ensuring treatment success while we focus on vulnerable populations. And it was planned that the state budget will finance the involvement of NGOs based on the state order. The state order system has been implemented. It was implemented 3 years ago in the HIV service, and this is about detection, support of cases, supporting the cases. There are persons who can be lost to follow-up, and the NGOs are able to return these people back to treatment. There's good experience in the city of Bishkek, where the international Crescent NGO is working well. They were able to effectively reduce the proportion of those who are lost to follow-up. Now, it used to be 38% in the city of Bishkek. Now it's 10% of those who are lost to follow-up. Thank you very much for your attention. Finished. Open for questions. Thank you very much, Dr. Atarkul. That was a very interesting presentation. I'd like to say that in all of our countries, there's ongoing intensive work to control TB. Thank you very much. And we are finished with our first plenary session, and we have already, we're using the coffee break time already, but I would still like to invite you for discussion and ask questions. Yes, please answer. I hope that the microphone is working.
Уважаемая Валентина Александровна, спасибо вам большое за вашу презентацию. У меня
вопрос. Thank you for your presentation. I have a question about mantle and dye skin test, because I understand that according to the order of the Ministry of Health, mantle is done to children under 8 years of age, and dye skin test is used for children older than 8 years of age. I saw several children who had mantle tests for several years, and they were under 8 years, and every year the mantle test result was positive. and only after that they're referred for dye skin test. I asked the physiatricians why so, and why can't they do the dye skin test right away? Because these children had positive monthly test results every year. And the dye skin test came out negative for them, but they said that they have to follow the order of the Ministry of Health. There's nothing they can do about it. I'd like to find out what was the reasoning for this because, and why can't we do dye skin test for children under 8 years of age? That's an excellent question. Thank you very much. Well, probably everyone, a lot of you understand dye skin test is in use, it's being introduced. And clinical recommendations, and without them, we cannot cancel tuberculosis diagnostics. So without, because there is a revaccination with BCG, it's still being done. There's so much interrelation. There is a battle between Rospotrebnadzor and the Ministry of Health because Rospotrebnadzor does not listen to the Ministry of Health. Says it's a time of Anishenko, who used to be the chief center of physicians back in the Soviet times. Now, this has already been formalized, and clinical recommendations on LTBI are with the Ministry of Health. We're waiting for approval. It's rather difficult to go through all the steps of approval in our organization, but a lot of TB doctors are already following the procedure that you described, doing mental tests. Let me add to what you said. In the Republic of Uzbekistan, we used to purchase, well, again, based on your recommendation, first tuberculin, and if the mantle test result was positive, we would do the dye skin test. And now the new TB program has budgeted for a small amount of tuberculosis for for very young children who did not receive their BCG shots for some reasons, and also we are going to do the tests like dye skin test and quantiferon for risk groups and contacts. It's a correct decision, and our whole TB care community holds the same opinion. But it's time for another battle to get this message through. Yes, Nazargun, please, you have the floor. Thank you very much. I have a very short answer to Katagula Ahmad Bekovna. Thank you for your presentation, which was very comprehensive. I have a question about transition towards outpatient treatment and within the PHC settings. Marat yesterday talked about financing. Now I would like to hear from you. What was the feedback about this from patients, nurses, and doctors in PHC, and how did this influence quality of care? TB doctors are conservative, and a lot of them were against outpatient treatment. Even the talks about outpatient treatment opposed objection. So there were talks about first providing continuation phase during in outpatients, then the intensive phase. So those who know the clinic, you know that the condition of TB patients quickly improves, and patients ask for their treatment to be done at home. And doctors themselves didn't let them go home. Now doctors started to understand that this mindset, and there was a lot of explanation for doctors so that people would understand the principles of outpatient treatment and the benefits of it. Well, the city of Bishkek and Chuy province ensure 39% of coverage with outpatient treatment. Even patients with positive sputum microscopy results can receive their outpatient treatment. If there are no contact children in their families, even MDR patients are allowed to have their treatment in outpatient settings. If there are no adverse effects, or if they're moderate, first or second degree of adverse effects, and then doctors are able to manage side effects. Patients' feedback was very positive. They felt joy, and stigma was reduced as well. Other people didn't know that this was a TB patient. They could come and receive their treatment. So what was the financing for this? We had a long discussion about this yesterday, but the key point we learned that Uzbekistan is only starting to do this. So hospitals thought that they would keep the patients longer and receive more income. And when COVID pandemic has a strong influence and patients disappeared, only 30% of beds were occupied during that time. Of course, they started making less money, and because patients were kept for 6 months and longer, they spent all their earnings to keep certain patients. Now, directors are good at assessing these aspects. Now, when the condition of the patient allows for outpatient treatment, they're allowed to have their outpatient treatment, and the hospitals are making the money following the case-based financing scheme. Our health insurance fund was also involved into this. They were they were fine. The hospitals were finding relapses. We know, all the TB doctors know, when you inform a patient that he or she has TB, they're stressed. And when they're diagnosed again with TB, that would lead to even more stress. And due to this stress, these patients tend to leave hospitals and go home. But patients cannot stay in their families for a long time without treatment, and they return several days later, or sometimes a month later. But usually they come back to hospitals within a week. There was one case when the health insurance fund would pay the same amount for a patient, regardless of the length of stay of this patient. We are going to make adjustments to this payment schemes. We also have to make adjustments into financing the cases for treatment patients with extrapulmonary TB, bone and joint TB. Now we have to revise our DRGs at the end of this month or next month. We'll take these aspects into account, and we'll adjust the coefficient for DRGs that would consider these other cases of TB. I'd like to add about the experience of outpatient treatment from day one. And it's been many years that we've been implementing this. We adapted WHO recommendation to the context of Uzbekistan. And we also took into account local mindset. If it's a larger family or a family where one of female members of the household is pregnant, it was not, outpatient treatment was not recommended. But our country adopted a charter of patients with TB, and patients have a right to choose where they will get their treatment, of course, if it's not against the rules of epidemiological control. In our country, patients with MDR-TB also are entitled to a treatment at home. Video-supported treatment really helped with this. So patients are at home, they take the drugs at home, and they are controlled in an online mode. Does anyone else have questions? I think this microphone can be turned on. No? No. It's dead. Yes, please, you can come up front. Good morning, dear colleagues. I have a question, a representative of Kazakhstan. I wanted to ask her personally, but I decided to ask this question publicly. I work for childhood TB department of dispensary number 5, and it quite often happens, well, we neighbor Kazakhstan, mothers, which is new mothers that have TB come to our dispensary. I'd like to find out, we clarify with them how they were detected or diagnosed with TB. It was pleasant news for us that all new mothers undergo fluorography after they give birth. So how do you technically do this? Do you have fluorography machines at maternity clinics, or do you send them to TB care facilities? But all the new mothers are discharged from maternity clinics once they've had their fluorography examination. Does the lactation reduce because of fluorography? Well, it's not recommended to do an X-ray during this period. So we had a lecture. Alfia Raufovna delivered a lecture during our professional development training. Does radiation influence lactation? Absolutely doesn't. Well, if this is about digital technologies. Yes, as a rule, we have digital machines installed everywhere. So annually, we're seeing very many mothers with young children, 3 or 4-year-olds even, and they were found to have even destructive forms of TB. I need to explain that mandatory condition is that during pregnancy, the husband of the woman must go through an X-ray examination. Let's give the opportunity to her to answer. Yes, thank you for your questions. Yes, we have this provision in our legal and regulatory documents. 100% of new mothers have to have fluorography examination. The fluorography machines are installed in all the maternity clinic. They are 2 after delivery. They have this fluorography examination. If for some reason they don't do this, then the family where she lives needs to bring some medical certificate and a clean bill of health for the whole family, and that they have had this fluorography scanning and they're found to be healthy. So 2 years later, after this screening, the same woman has to go the screening in the PhD facility. But again, as I was saying earlier, in Uzbekistan, it's before delivery. Is the husband of the woman has to have an X-ray examination. Atarkol, you wanted to ask a question? Faulty microphone, doesn't work. Seems to work. Dear colleague, one of your slides showed information about individualized regimens and that you cover 100%. And I have a question. What's the proportion of coverage with shortened regimens if individualized regimens cover 100%? Or maybe I misunderstood the information on the slide. Yes, based on indications, we provide 100% of coverage for our population with individualized treatment. As for shortened regimens, they're in place under projects. 4 of our provinces are involved into these projects. As for shortened regimens, we haven't yet ensured 100% of coverage. I think we will make a break for 10 to 15 minutes. The coffee break has already been served, and we'll come back to this conference room.
Конечно. Бияқта қарап тұрайын.
Ертең көріп еткенсің де. Он хорошую идею дал, да? Уважаемые коллеги, я прошу вас
Dear
занять.
colleagues, you're kindly asked to take your seats. We're starting plenary session number 2. Okay.
Mr. Bjorn, Dr. Bjorn, please. Ну, Эмиль, Эмиль приехал? Я не знаю. Нас будет? Позволите, я начну.
With your permission, I will start, and I guess my co-chairs will continue. So our plenary session is titled "Anti-TB Activities of the International Organization MSF." Nicholas Nasidze, the chief advisor, is co-chair, USAID Star Project, Bernd Thomas Janman, medical director, MSF, and project lead and clinical trials manager, MSF, Emil Kazonis. So the first presentation is to be practical, journey and next steps. So the presentation will be made by Emil, please.
Good morning, everybody.
Всех приветствую. Спасибо большое, доктор Бarbиева, за представление, за возможность побывать в Узбекистане и поучаствовать в данной конференции. Поздравляю национальную противотуберкулезную программу со 100-летней годовщиной. И также 90-летие специализированного центра фтизиатрии и пульмонологии. И вчера у нас было обсуждение замечательных планов и достижений в сфере борьбы с туберкулезом, как Узбекистан вписывается в эту картину. Мы говорили о том, что за все эти годы
and reviewed interpretations of that data are obviously key to this and to the ongoing cycle of research and development in the fight against TB. Today, I'm going to try and run through a summarized journey of TB Practical in order to give you an idea of what was involved when implementing. So, it's actually quite a big project. So I'm going to try and run through the milestones in the best time that we have. In total, the project is probably about 10 years from start to near finish. And the journey is across 3 countries and 9 hospitals, hundreds of trial staff, and thousands of data points, all from treating clinicians and community nurses to data managers, regional monitors, and laboratory staff to pharmacists, translators, and of course, drivers. I'll try to condense the story today, but for colleagues who are more interested in a detailed breakdown, MSF will try to be arranging an evaluation of the project early in 2023, and also will be reporting a transparent costings report at that time as well. So where do we start? We start all the way back in 2013. MSF initiated a broad analysis of treatment options available to staff, clinicians, and patients at that time who were confronted with drug-resistant tuberculosis. The unequivocal opinion amongst the patients, the clinicians, our partners, such as our partners in Uzbekistan, was that the long, toxic, sometimes injectable treatments with around about 50% success rate were not acceptable at that time. MSF took the decision to invest some resource into R&D, into new treatments, and responded to this problem. So, what was that response? In 2014, MSF worked with partners in Uzbekistan and across other countries to put together a consortium of drug-resistant TB specialists, Ministry of Health actors, NTP actors, clinical trial experts, and mycobacteriologists. A new clinical research program was initiated, which would include a randomized controlled trial and 3 sub-studies. There were 2 clear objectives of this program. One was to test new, shorter, less toxic treatments for drug-resistant tuberculosis against the current standard of care. And 2, if the new shorter treatments were found to be safe and effective, we would advocate for global guideline change. So this is the Practical trial. TB Practical is a randomized, controlled, open-label, phase 2/3 trial to evaluate the safety and efficacy of 6-month all-oral drug regimens containing bedaquiline and pretomanid for the treatment of patients with pulmonary rift-resistant tuberculosis. The trial has 3 investigational regimens, all built on the backbone of bedaquiline, pretomanid, linezolid at 600 milligrams, then reduced to 300 milligrams, and then given with either moxifloxacin or clofazimine or BPAL on its own. The control arm was locally approved standard of care in line with WHO recommendations, lasting anywhere between 9 to 18 months. In stage 1, which is the phase 2 part of the trial, safety and efficacy of the arms were tested at 24 weeks, and no concerning safety signals were observed, and all the 3 regimen arms were eligible to pass to the phase 3 part of the trial. In the transition assessment, the Independent Scientific Advisory Committee for the trial, after reviewing unblinded data, decided that Arm 3 would not be eligible to continue, and the Steering Committee decided for practical reasons that Arm 2, BPAL-C, would also not be eligible to pass. So therefore, Arm 1, BPAL-M, passed to stage 2 and would be tested against the local standard of care for 72 weeks post-randomization. As you can see on the slide, the primary efficacy measure was percentage of patients with an unfavorable composite outcome, including treatment failure, death, treatment discontinuation, recurrence, and loss to follow-up at 72 weeks. So, much to my relief, recruitment did eventually start in 2017. It ran for 50 months, and we opened 7 sites globally. 1 in Nukus in Kerala, Pakistan, 1 here in Tashkent in Uzbekistan, 1 in Minsk in Belarus, 1 in Johannesburg in South Africa, 2 in Durban in South Africa, and 1 in Pietermaritzburg, also in South Africa. In total, 552 patients were enrolled across all the sites, but with almost 45% coming directly from Uzbekistan alone. So that is a huge and noteworthy contribution. And we sincerely thank Dr. Parpiva, Dr. Zinaida, and Professor Liverker and their teams for their major contribution. During that 50 months, though, however, there were some challenges that were affecting the implementation of the trial. Social unrest in the vicinity of site hospitals, ongoing facility upgrades across sites, a very complex protocol with complex mycobacteriological procedures, and a fluctuating supply line and access to drugs was just some of the challenges. And of course, there was COVID-19. Conducting a global phase 3 trial during that period and during a new pandemic was a serious challenge for the teams. Practical did temporarily suspend new enrollments at some sites, but close partnership relationships, even more closer communication and pragmatic decision-making helped the trial continue. We ensured patient safety, staff safety, and data integrity through the COVID-19 episode. Then in 2021, something unexpected happened. By that point, we had randomized around 552 patients out of a target of 630. This was around 89% of the pre-agreed target. The Independent Data Safety Monitoring Board for the trial, who was regularly reviewing unblinded data from all sites, recommended that the trial be stopped, while the recruitment be stopped due to benefit. A predefined threshold had been met, and data showed that BPAL-M was more effective when compared to standard of care across all the countries. The trial sponsor accepted this, and the last patient was randomized on the 18th of March, 2021. And a couple of months later, we locked the database and we started to do the analysis. These are the results from the 2021 dataset. These results were presented at the Union Conference in 2021 and were also shared with the WHO Guideline Development Group in late 2021 as well. I won't spend too much long on this side, but this slide shows the table of characteristics of the group of patients that were included in the analysis. A good spread of characteristics can be seen across all arms, with a substantial number of patients included who had tested positive for HIV. These are the main efficacy results. The table shows the primary outcome measure at 72 weeks for the modified intention to treat population. As you can see, the percentage of patients with no unfavorable outcome is 52% in the standard of care, 89% for BPAL-M, 81% for BPAL-C, 77% for BPAL. BPAL-M regimen demonstrated both non-inferiority and superiority to standard of care, with a risk difference confidence boundary below 0. In terms of subgroups, this slide shows the forest plot of how the non-inferiority margin is in relation to certain subgroups. You can see that the BPAL-M regimen support superiority to standard of care was maintained across nearly all of the subgroups, apart from HIV positive individuals and patients from South Africa. Just to bring you back to the present day, just this month, we have received the final results from the trial and the final analysis. And we're going to be planning to present those final data at the Union Conference 2022 in November. So please look out for that. That extra data will, of course, provide more data points and give us more precision in some of the conclusions for the subgroup analyses. In terms of the main safety analysis from 2021, the number of SAE or new severe AEs at 72 weeks was 59% in the standard of care, 19% in the BPAL-M, 52% in BPAL-C, and 22% in BPAL. Conclusions we can draw from this data set is that 24-week all oral regimens containing a backbone of bedaquiline, pretomanid, tapered dose linezolid are both safe and efficacious in the treatment of rifampin-resistant tuberculosis. Treatment effects were consistent across nearly all the subgroups, and the efficacy hierarchy appears to be BPAL-M, then BPAL-C, then BPAL, then standard of care. The safety hierarchy appears to be BPAL-M, followed by BPAL, followed by BPAL-C, followed by standard of care. So as I mentioned earlier, we shared our randomized controlled trial data with WHO in late 2021. And alongside the trial data, we also shared sub-study data. We had 3 sub-studies in the research program. One was an economic analysis sub-study on the economic assessment of the new regimens, both for patients and for institutions, health providers. We had patient-reported outcomes sub-study, telling the story of the tolerability of these new drugs for actual patients and their experiences in their day-to-day lives. And we also had a pharmacokinetic, pharmacodynamic sub-study to try and assess the way that the drugs interact with the blood in the body. In May 22, as we heard from the previous presentations yesterday, we were very happy to see the new rapid communication from the WHO and the news regarding the new guidelines, which will include the option to use 6-month BPAL-M and BPAL for patients with RIF-resistant TB. And we also look forward to the full guidelines coming out later this year or earlier next year. So coming back to the overall journey, we're now kind of in the final stages of the project. We plan to share the main and final results at the Union Conference, but also in peer-reviewed journals over the coming year. We're in the process of closing out trial sites in South Africa, in Belarus, and I'm traveling to Nukus next week and then back to Tashkent to close out the trial sites here. And we're developing post-hoc research ideas now that we've seen the data. And we're also trying to decide and plan for how we will share the data post the project is finished to try and make this data available to TB researchers in the coming years. This project would not have been possible without our key partners in Uzbekistan. So thanks once again to Dr. Parpiva, Dr. Zinaida, and Professor Liverco. And of course, thanks to all the different partners in our global collaboration. Finally, a special acknowledgement of all our patients who took part in the trial and made finding this new treatment possible. I think I will stop there. So thank you very much for your attention.
Thank you very much for the very interesting presentation and very encouraging results to be practical. And from the perspective of Uzbekistan, we must say that this is a kind of contribution of the country to the world health and world research. So, and we are happy for acknowledging this in your presentation. Thanks a lot. We'll we would like to now announce next presenter. This is Alexander Nikiforov. Алексей Никифоров, заместитель медицинского координатора МСФ Россия.
Medical coordinator, MSF Russia. Short oral regimens for people with drug-resistant TB in the Russian Federation. Thank you. Good afternoon, dear colleagues. I would like to echo the congratulations by other colleagues who have spoken before. It is my great privilege to present our study at such a representative forum. And after the presentation on the 6 months regimen, our approach might seem obsolete because we suggest 9 months treatment regimen so far. And well, we have been developing it for a long period, but finally we started implementation in 2021. The point is that MSF has been long dealing with TB in the Russian Federation, and as you can see, back in 1995, the first TB treatment program was initiated in prisons of the Temur province, and it happened like elsewhere in the former Soviet Union because we had failures in treatment, and especially we had a lot of TB cases in prisons. And I guess you are all aware of Dr. Natalia Veshneva. She spoke at the TB Congress in Brussels, and with tears in her eyes, she said how tired she was because she had to bury her patients. And I mean, then MSF responded quickly, and 1 month later in Mariinska, the project was initiated in prisons, and it lasted till 2003. And then we initiated the next project in the Chechen Republic. Again, there was due to sad reasons, because after 2 wars, The whole TB service in Chechnya was almost ruined, and no TB hospitals remained there, and 10 or 12 TB doctors only were available. So we had to restore the health system, and we helped them too. So initially we were dealing with only drug susceptible TB, but when we managed to restore the laboratory service, so we initiated treatment of DR-TB, XDR-TB. So gradually we were progressing. And after that, we started managing comorbidities. And for the first time there, we started using new drugs, bedaquiline, dilamanid. Beginning 2018, we were able to establish friendly relations with Arkhangelsk province, with Andrei Mariandashev, who helped us a lot to start the treatment with XDR. We concluded a memorandum of understanding with this province. In 2021, finally, we started our project with short treatment regimens. Irina Anatolyevna already spoke about this, that incidence of TB in Russia, luckily like in all former Soviet Union countries, was decreasing over time. So it's about 30 per 100,000 population now. Why did you think I wrote this? If you rush, you will make people laugh. We thought that the fact that we were working slowly was a bad thing. In 2015, we signed an agreement with Arkhangelsk province, and only in May 2018 we had the first patient. And you might ask, what were we doing for 3 years? But it turned out to be good that we didn't rush. So back then we had the 9-month treatment, but it included injectable drugs. And if we did start it back then we would start treating people like that, and nothing good would come out. Luckily, the World Health Organization gave us a great gift. In 2020, in its recommendations, it mentioned that any patient, whether it's a child or adult, has a right to a shorter treatment regimen, including bedaquiline. And relying on these recommendations, we developed a new protocol based on which we started treating patients without injections. Only tablets were administered. This was a unique event. No one still in Russia deals with this, except for us. In 2021, the rest of the recommendations were supported in our work. So this 9-month treatment course with a study of 4 new drugs, using only 4 new drugs, which are oral only drugs. We didn't limit the patients, meaning who is eligible for treatment. We included practically everyone aged 3 years and older. We couldn't enroll anyone younger than 3 years of age, unfortunately, but we didn't have any such patients anyway. We worked in Arkhangelsk and Vladimir provinces. How did we end up in Vladimir province? Well, our TB doctors worked so well, and during the time while we were preparing for our project, the number of patients in Arkhangelsk province reduced critically, and we realized that if only we work in Arkhangelsk Oblast, it will take us 10 years to do our work. So we launched this activity in Vladimir province as well. And well, the fact is that in these 2 oblasts or provinces, as many of you probably personally know these people who are in charge of health services in those provinces, Dr. Mariandashev and Dr. Lyshenkov. They're in charge of health departments in these provinces. These are 2 unique doctors, and they're one of a kind in the probably whole post-Soviet
area. So we approached them with our proposal and was immediately supported by them. And that for 20 years already, they are take part in different scientific and practical projects. It was not news for them. In Arkhangelsk, there is a Northern State Medical University, which has an ethical board entitled to approve protocols of scientific projects. In addition to that, they have a very well-equipped laboratory which have the capacity to do a number of tests. Back then, they did have HINE, or at least access to HINE tests. And that was part of the protocol. All the other capacities to do testing. Now, according to the initial plan, we started treating patients in February 2021, and we were supposed to finish our project in August 2024. But excellent results of 6-month project were now ready, and you just heard about the results of that project. So we have our own ambitions. We thought, why treat them for 9 months if we can treat them for 6 months? So we started to actively prepare for the implementation of the 6-month treatment. And now, Ritonamide is not yet registered in Russia, and we cannot bring it into the country without registration, only if there's a permission of the Ministry of Health. So we are finished with our preparations for the 6-month course. Once we have the opportunity, we will restructure our working routines. But so far, we're still receiving patients, and we'll share preliminary results. The criteria for inclusion into the project are shown here. They're comprehensive, and practically any patient can be enrolled into this project if he or she is diagnosed with MDR-TB. And the exclusion criteria are clear for all. Why specifically these are criteria for exclusion? The treatment regimen itself, 4 drugs. These treatment regimens are designed for patients with MDR and XDR-TB. Since there are limitations when it comes to access to drug and the possibility to use bedaquiline in children, back then that was the limitation and restriction, and very recently this limitation was removed. The Ministry of Health decided that bedaquiline could be used for younger children. But the regimen is on bedaquiline, linezolid, clofazimine. So in Russia, clofazimine is not registered. Unfortunately, we have to bring it into the country through the permission of the Ministry of Health for a specific patient. That takes a lot of paperwork, but we have overcome this, and we're doing that. So patients who have resistance to fluoroquinolones, according to the current classifications, it's not yet XDR, but when we were starting our work, that was considered as XDR. Right now, it's called pre-XDR. So for those patients, instead of levofloxacin, we added laminate, which Andrei Olegovich told you about yesterday. So it's treatment based on vital indications. So the laminate was added to this treatment regimen. So all drugs that were tested a long time ago and proved that they work well. Since the use of these new treatment regimens based on WHO recommendations is possible only through an operational study, we focused on identifying adverse effects and tracing them, controlling them. Almost all TB doctors don't really like to report adverse events. If you speak to chief physicians, and they will tell us, well, you will spoil all our statistics because of these adverse events. But we must do this, so we very closely monitor adverse events. So, and in order to ensure adherence of patients to treatment, we try to use a social approach as well. So that was during the COVID times. We started with back then. And people faced additional problems. So we attach huge attention to social support and the psychological status of the patient. Both in Arkhangelsk and Vladimir, we have psychologists who work with patients. First, they assess the status of the patient, and then we help to the extent that we can. Now, preliminary results. At the moment, when I was drafting this presentation, the study included 107 people, and 66 already had some results. Well, I cannot compare to previous presentations with effectiveness, treatment success of 80 or higher percent. Our treatment success in Vladimir is 64%, and in Arkhangelsk, it's 73. Yesterday, in one of the presentations, they said that the presence of HIV infection in the patient undermines the treatment success by 7 times. In Vladimir, every 1 in 4 patients was with HIV infection. In Arkhangelsk, there were much fewer of these patients, and the results were different. But there were other factors that influenced treatment success. But despite anything, we're doing better than other dispensaries in Russia. In Russia, treatment success rate is 53%. So mainly patients that we have, patients with XDR-TB, are a majority in our project. And the challenges. So when we were starting, clofazimine and delamine were not registered in Russia. And everything had to be brought into the country through a special permission. Now, the laminate has been registered. So, but even then, for 9 months, it took the company 9 months to bring the drugs into the country. There were some problems there. In addition to that, beginning in 2021, everything that's related to Hind tests stopped to be brought into Russia. The supplies stopped. So we pulled out all the stocks that we had, and thank you. I would like to thank Irina Vasilievna, who did Hind tests at her institute. So Andrei Olegevich and Dr. Vasilieva had Hind test supplies, but they ran out of the supplies very quickly. And it was also mentioned that we have a real-time PCR in Russia. We were able to convince our advisors that this is an effective and quality way of molecular diagnostics of drug resistance. I'm sorry, drug sensitivity. No, so this made our task easier because we were not able to add new patients to the project on time, and because they were already treatment under the protocol. And they cannot be included according to the protocol. So we're doing everything to be the first ranks. And we're continuing our study and working on the 6-month treatment based on regimens that were just mentioned using ritonamide. And we already submitted the documents for consideration to the Northern Medical University, and MSF has already approved the protocol that we prepared for this study. And the Russian Society of TB Doctors is supporting us. We received letters from Evgenia Anton that she's happy that this is happening and welcoming this endeavor. And so we're preparing. And very soon, we will have autonomy on our hands, and we'll continue implementing this wonderful treatment regimen. Thank you for your attention. Thank you very much, Dr. Nikiforov, for your presentation, and wish you all the possible success. Also, our colleagues, Dr. Mariandashev and Lechkov, in their further work. Now, the next presentation is about MSF activities, a strategy to reduce TB burden in Karakol, Pakistan. And the presentation will be done by Dr. Somel, a clinical trial medical lead. That's it. I would like to say that I had a chance to visit Karakol, Pakistan very recently. I'm very impressed by the work done there, and specifically the activities of MSF. Спасибо, господа.
My name is Dr. Somo. I'm from MSF Nugus Project. And on behalf of MSF Nugus Project team, I'm going to present our activity in Karakol, Pakistan, and the strategies to reduce tuberculosis burden. Here are the presentation outlines. So as a brief context, MSF project in Karakol, Pakistan started in 1998 as a DOTS Plus project for the management of drug-sensitive tuberculosis. A drug susceptibility test, DST study, was done in 2001 and found that 13% of the new cases and 40% of the new retreatment cases were MDR-TB. And based on the finding of the study, a DOTS Plus project was initiated in 2003 in order to tackle MDR-TB problems in Karakol, Pakistan. The first MDR-TB patients was cured in 2005. In 2011, a comprehensive care for all TB projects was started, and later on, it was expanded to all the districts in Karakol, Pakistan in 2015. A pilot study on the WHO recommended 9 to 12 months short course treatment regimen was conducted from 2013 to 2015. The TB practical clinical trial project was started in Nugus in 2016, and the trial in Nugus is expected to finalize by the end of this year. And following the successful outcome of the TB practical, the new treatment regimen was introduced in Karakol, Pakistan as a introduction as a smart operational research in June 2022, and the smart operational research will continue in next year. In terms of the laboratory diagnostics, the DST for beta-galactosidase, clofazimine, and moxifloxacin were introduced in late 2019 or early 2020 as a routine test for beta-galactosidase, and beta-galactosidase, including the clofazimine linezolid, under the programmatic settings. MSF also planning to introduce the new targeted genome sequencing to assist the laboratory in conducting the operational research, and in order to diagnose the resistance to those new drugs. So having a good collaborations between MSF and the MOH, Karakol, Pakistan, and Uzbekistan is one of the key strategies to MSF success in the country. MSF implements hands-off approach by providing technical support to the Ministry of Health, such as training the healthcare workers, including MDs, nurses, and attending the consilience for case discussions. MSF also involved in the DRTP treatment guideline revisions in collaborations with the MOH. In terms of the medical supply, MSF support the procurements of second-line and TB drugs as for the purpose of gap filling, And MSI also provide the predominance for the smart operational research and all the lab consumables and reagents for the regional lab in Nukus. Other supports also include the health information management systems for drug-resistant tuberculosis, infection control and prevention, which includes the renovations of healthcare facility and proper destructions of expired medical items and medical waste management. In terms of the laboratory, MSS provide the technical support to MOH lab technicians and support the external quality assurance processes. Additionally, the innovative approach to the project implementations by embedding new evidence or bringing in new technology has been a cornerstone of the project's activity. One good example was the TB practical clinical trial, which found a shorter, less toxic or oral treatment regimens for rifampicin-resistant TB and has significantly contributed to the global effort and to the global tuberculosis community. We also embrace the technology-assisted interventions, example the video observed therapy, which was introduced in late 2020 to overcome the barriers associated with lockdown due to COVID-19 pandemic, so that our patients were able to continue the TB treatments remotely from home. MSF also embedded on the patient-centered care during the project's planning and activity implementations. In terms of the social support, food parcels are provided to the needy patients. We also understand that psychosocial counseling is an important component of the TB program, and that's why MSF has initiated a 6-month pilot peer supporter intervention, where ex-TB patients were recruited and trained to provide the psychosocial counseling sessions to the individual patients. A pre-assessment will be done before the pilot interventions, and then the post-assessments will be conducted after the 6 months of the interventions. There's also a possibility to scale up the peer support interventions if the evaluation shows positive results. And lastly, the health promotions and community engagement activity is one of the core components of our project's activity. And I will present more about it at the later part of my presentations. This figure shows the morbidity and mortality of drug-sensitive TB and drug-resistant tuberculosis in Uzbekistan between 2015 and 2021. The blue column represents the number of patients started drug-sensitive tuberculosis treatment, and the red column represents the number of patients started DRTB treatments. We noticed that the burden of drug-resistant tuberculosis in Uzbekistan was constant throughout the 7 years, averaging around 600 patients per year. The proportions of drug-resistant tuberculosis patients started the treatment out of the overall TB patients was also stable, which is around 30%. And this table presents the total number of samples tested rifampicin resistant on gene expert and the number of patients started drug-resistant tuberculosis treatments from 2015 to 2021. We do not have the number of patients who tested rifampicin resistant, and that is why we will use the number of samples tested resistant on gene expert as a proxy to determine the number of rifampicin resistant in order to compare the diagnostic rate and the treatment initiation rate. The reason we use the number of sample tested rifampicin resistant is that the gene expert is mainly used for the diagnostic purpose, and it is unlikely that the patients will submit sputum samples for more than 1 time. So the data can be very close to the actual number of rifampicin resistant patients. So as can be seen from the table, there were more patients who tested rifampicin resistant than the number of patients who started MDR-TB treatment. So on average, around 37% of the patients, or around 270 patients per year who tested rifampicin resistant, but did not initiate MDR-TB treatments. There are several explanations as to why there is such a huge discrepancy though. The first explanation is obvious because we use the number of sample tested resistant rather than the number of patients. And the second is our database does not capture the number of patients who initiated treatment for less than 1 month. So those patients will not be included in the number of patients who started treatment. And lastly, there are some rifampicin resistant patients who also had cross resistant to other group address. And in this case, they will be counted as pre-HDR or HDR-TB. So it is understandable that 37% of the patients who tested rifampicin resistant but did not initiate the MDR-TB treatment is overestimated, and the actual number could be lower. Nevertheless, it is also important for us to know the actual number of dropout rate and to understand the reasons for dropping out in our project so that we can improve the treatment retentions and improve the quality of care. This figure shows the treatment success rate for drug-resistant tuberculosis per year. The blue column represents the number of patients who achieved favorable outcomes, and the red column represents the number of patients who achieve unfavorable outcomes. The treatment success rate was on a rising trend that increased around 17% from 67% in 2015 to 78% in 2021. However, there needs to be careful in the interpreting the treatment success rate because those patients who initiated treatment for less than 1 month were not captured in our database. Hence, these patients were excluded in the analysis. Also, there is 268 patients from 2021 cohort that are still on treatments, and therefore the treatment success rate for 2021 is not represented. And lastly, patients recruited for TB practical clinical trial were excluded from this analysis also. This figure shows the distributions of unfavorable outcomes among drug-resistant tuberculosis patients per year. The rate of loss to follow-up has been on a decreasing trend. It decreased for 58% from 19% in 2015 to 8% in 2021. Similar to the loss to follow-up rate, the rate of treatment failure also decreased from 7% in 2015 to 2% in 2021. However, the mortality rate remained constant throughout the 6-year period, which is around 6%. This slide shows the structure of TB lab supported by MSF in Uzbekistan. The regional TB lab is based in the Republican phthisiology and pulmonology hospital, where majority of the sputum tests are conducted. And in addition to the regional TB lab, we also have 3 peripheral labs where there are sputum smear and gene experts are conducted. All the sputum cultures and DST for second-line drugs are conducted in the regional lab in Nukus City. In addition to the patients from Uzbekistan, the regional lab from Nukus also receives samples from horizon regions for culture and DST. This figure shows the number of TB patients with resistant to and the resistant rate to the bedaquiline, clofazimine, and linezolid per year. The pie charts represent the number of patients with resistant to a particular drug, while the dotted line represents the resistant rate. The resistant rates of bedaquiline, linezolid, and clofazimine was highest in 2019, when DST for those drugs was first introduced, and the resistant rate decreased in the following year when there were more sample tested DST for those drugs. So coming back to the health promotions and community engagement activities, the patients, community, and stakeholders are the core of our activities. Some of our activity include the posting health-related messages on the TV, local TV, or on the radios. We also utilize the social media such as Telegrams for promoting healthy lifestyle. All the health promotion activities are conducted in collaboration with the Ministry of Health, Kazakhstan. In terms of the health talk, our team regularly engage with school and mahala in the community for conducting in-person health promotion sessions. The pictures on the right shows some of the sessions that our team conducted in the primary school and in one of the bazaar in the community. We also utilize the International War TB Day and the War Antimicrobial Resistant Week for raising awareness and promoting healthy lifestyle in the community as well as healthcare facilities. And here I want to highlight some of the major challenges that we encounter during the activity implementations. First, the emergence of resistance to new or repurposed TB drugs is alarming. It is likely that resistance to beta-glucan linezolid or the clofazimine will continue to exist in the future. Second, we also observe that directly observed therapy can be a hinder factor for the patients to adhere to the treatment because it is not patient-centered and it requires a significant commitment from the patients. Third, there are limited diagnosis and treatment options for pediatric patients with MDR-TB patients. Fourth, the stigma around TB is still high in the community, and the majority of the patients, they also have social and financial burdens, which can be difficult for the patients to adhere to the whole treatment durations. And fifth, the burden of DRTP in Kazakhstan remains the same throughout the 7 years period, given that the treatment success rate has significantly improved. This phenomenon needs further study for better understanding so that targeted interventions can be provided. And lastly, the high number of patients who tested rifampicin resistant but did not start the treatment or lost to follow-up within 1 month is a concern for us. This will be one of the top priorities for MSF, our projects in Nupus for better understanding and to provide practical solutions to support the MOH Kazakhstan. Nevertheless, there are opportunities that we can utilize to improve the quality of care and reduce the burdens of tuberculosis in Kazakhstan. The availability of 6-month treatment regimens for MDR-TB can be a game changer. Together with the Ministry of Health, MSS will make sure that all eligible patients will receive these novel treatment regimens. Additionally, the introductions of new genome sequencing technology can help us better understand the epidemiology of second-line resistant and then to detect, to early detections. We are also interested to explore the possibility of self-administered therapy or digital assisted therapy for MDR-TB care under a programmatic settings. Furthermore, there is an opportunity to enhance the other case finding in the community and to expand the existing in health community engagement activity so that we can reach as many community as possible and people can benefit from our activity. Lastly, MSS will explore the barriers from both the patient and health facility perspective for assessing TB care and the practice around end-of-life care in Kazakhstan. So in conclusions, the treatment success rate for drug-resistant tuberculosis is improving, and there's an options for a shorter, less toxic or oral treatment regimens for MDR-TB, which we can embrace to cure more patients. However, increasing treatment success rate alone will not be enough to reduce the tuberculosis burden. More effort should be made to address the barriers in assessing TB care, such as stigma, financial burden associated with loss of income, or indirect expenses related to TB treatment by incorporating patient-centered approach and empowering the patients and the community. Thank you very much for your attention.
Thank you very much, Dr. Moore, and really very impressive work done in Карагалпакстан. У нас есть следующая выступающая.
We have our next speaker, and I'm especially pleased to announce her, Ruzila Usmanova, clinical trial medical leader, National TB program, and she will inform us on TB practical clinical trial experience. Thank you so very much for your introduction, and thank you so much for this opportunity to speak. Emil has shared the results of TB practical globally, but allow me to present our experience with implementation in Tashkent and Tashkent province. So the implementing agency is the Republican Center for TB and Pulmonology, specialized scientific and practical center of the Ministry of Health of the Republic of Uzbekistan, and the primary investigator is Dr. Nargiza Parpieva. So at our Tashkent side, this is Irina Liberko, and the sponsor definitely is MSF. We have opened in December 2018. On the 14th of December, we had the official launch of our site, and this is the historical image, which we are always happy to see and we like to see. And we have good memories of this event. So the site was initiated in Tashkent on the 28th of December 2018. So there was some New Year gift, because it took us 9 months to get prepared to open the site. And the first patient on the site was randomized on the 23rd of January 2019. So how we did the enrollment. So just short information about the design of the study. Actually, it was absolutely the same at all the sites mentioned by Emil already, and the laboratories where we had gene expert, our center, dispensaries, and the city dispensary and dispensary number 5, some at the 8 centers. So we collected all the gene expert test results, and we used some exclusion and inclusion criteria to filter the patients, and we discarded those we couldn't enroll, and the rest were enrolled. Mostly our patients were enrolled based on gene expert, because actually we had very stringent criteria for enrollment. So the testing should not last more than 4 weeks, and Hein was mostly using culture materials. That's why we were mostly using gene expert results. So resistance was identified, older than 18 years, pre-screening was mandatory, and it should be the Tashkent residents, since up to 108 weeks was the observation period, and it was essential for us to preserve the patients for the health follow-up period. And also we were enrolling people from adjacent areas next to Tashkent city, but we managed only to enroll some 10 patients, and after that we stopped randomization and enrollment to the site. And we actually offered consultations, 1, 2, 3, sometimes third consultation was also offered. The psychosocial support was provided as well, and investigators who offered those consultations were very helpful. So the patient had to sign the consent form in Russian, English, and Uzbek. We used Russian and Uzbek versions mostly, and after that form was signed, we did the screening, and following successful screening, and if the patient matched all the eligibility criteria, then we did the randomization of patients. Overall, over this period since start till the end, we identified 350 patients using expert, and we had one patient using high test results. But anyways, we also tested him using GeneXpert. That's why we haven't identified him separately. And 112 primary consultations, 112 patients agreed to come to those primary consultations. 61 of them signed informed consent form, which means almost half of them said no after they read that informed consent form for various reasons. And then we conducted screening of 60 patients. So one patient signed the informed consent form, but then her mother came and said, no, we will not participate. And actually family played an important role in our country. And then we enrolled 55 patients in our study. So 55 patients were randomized. So 5 were excluded based on the screening results. So for some reasons, for some test results, those patients were not eligible, and that's why we had to tell them towards the Ministry of Health treatment.
The main reason why we didn't include patients to our study in Tashkent and Tashkent region because they were patients under 18 years of age and then go through pre-screening when they confirmed their address of residence in Tashkent, and they had to be involved for quite a number of weeks, and that's why they were not. So we started the standard treatment of MDR and XCR, and the patients would. So severe clinical condition of the patient, if the patient was at ICU or could not be transported and cannot be brought to our centers. Extrapulmonary TB was excluded. Some patients couldn't be found. They were lost to follow-up. And 3 patients rejected inpatient treatment. There was a protocol, I will remind you, where we had to treat patients in a hospital for the first 8 weeks, and the protocol was later changed, and we started treatment within our TB protocol in an outpatient setting from day 1, and it went quite successfully. 51 patients refused to sign an informed consent form, and since this is an international clinical study and the monitoring is very strict, everything needs to be in line with the protocol. While we were monitored for about 3 months, we didn't enroll any new patients, and we were told that we were working well, and we started enrolling patients again. And for other reasons, 51 patients were not included into this study. And Emil already spoke about this. We had 2 stages. There were 3 shortened treatment regimens. ARM, that's what they're called. The first regimen, Bipal with moxifloxacin. The second one, Bipal with clofazimine. And the third regimen is simply Bipal. And control group received standard treatment. During the second phase, the Bipal with moxifloxacin remained. And during the second stage, we enroll more patients for Bipal M and standard treatment. I would like to show the next slide. I think that for us, the X-ray effect is important. As for TB doctors and as for clinicians, culture test is also important because it's an infection control. The patient may stay at home and quite safely. As for clinicians, it's for us very important as well. I personally, I will say for myself, I was afraid to start in this clinical study because back then when we started, we treated patients for 9 to 11 or up to 20 months, and now it's only 6 months. And how so? Are we going to cure MDR or SCR in these patients? I didn't personally believe this. And I always say this and I admit to this fact. But after the 10th patient's results, I was now reassured and said that this is a reality and that this needs to be continued. This is a great opportunity for patients to be cured quickly and ensure their adherence to treatment to the end of the treatment. So we have selected several X-ray images, which are quite informative to demonstrate to you. This is the male patient, 35 years of age, socially vulnerable, has been convicted before and has harmful habits. It was a total SDR case. He was resistant to the first and second line drugs. Sensitivity to Nexanet and Daquilin was available. This patient was on BPAL, and we were preparing this patient for surgery, both morally and physically. We were preparing him because we realized that with this extra drug resistance, the cavity would not close, but it did close in 6 months, and we were surprised and we were so full of joy that the patients will not have to undergo surgical treatment. Next patient is a female patient. I didn't want to enroll her into the study because there was a massive process in the beginning. She was emaciated, small and thin, but because we never picked patients and she met all the criteria for inclusion, we enrolled her into the study. And at that moment, she received BPAL with moxifloxacin, but it turned out that she was resistant to fluoroquinolones. But according to the protocol, we didn't have the right to change the treatment. So this patient was receiving the BPAL regimen. This is another X-ray image, and that's not after 6 months of the treatment. This is the image after a year after the start of the treatment. Because 6 months later, we suggested surgical treatment, but the patient refused and her parents refused. But we've been monitoring these patients later, and according to MOH requirements, we were supposed to do the X-ray monitoring. So a year later, after 12 months, we saw that all the cavities closed. In this patient, we always told patients that their blood will retain some concentration of the drugs for 3 to 6 months in some patients. So this concentration of drugs and social status of the patients are important. And we were very happy for this patient because it was a young girl, she about 20, and very young, and we were happy to obtain this result. Another formative example, this was a young male patient of 27 years. Again, the cavity was quite large, but 6 months later, the cavity closed, and the scar that you see here, it became even thinner 6 more months later. So the patient is all well and didn't have to undergo surgery. And of course, COVID. In 2020, COVID affected our work as well. And the 16th of March 2020, quarantine was announced and it was locked down. Everyone remembers it very well, and we have to find a way out. How to deliver this treatment to our patients was the question. And very urgently, our team of about 35 people, we still remember that on weekends, on some days, we would go out and collect drugs and deliver them to the patients so that they don't interrupt their treatment. For standard treatment, standard regimen, a small interruption might not do a difference, but with this new treatment regimen, we didn't want to have any interruptions, and that's when we had to introduce video supervised treatment, and there was the smartphone, access to the internet, good connection, a possibility to record a video, and this could replace directly observed treatment. All patients were on a DOT before that. A patient would come, receive the dose of drugs, and would leave, including Sundays, because 6 month shortened courses implied drug administration 7 days a week. We are thankful to sponsors because it was supported. The patients, they paid for their travel expenses, and food packages were provided to them. And there were also psychologists and staff who have also been helping us, because without then we wouldn't be able to achieve the success. So on the 17th of March 2020, our first patient started their video supported treatment or video observed treatment. In April 2020, because of these unusual circumstances, we approved the protocol. Developed it in March and April and then got it approved. This was a protocol on treatment of our patients with the video observation. What did we use? Since this was a situation, as it was an out of ordinary situation, and we're again thankful to our sponsors who supported our patients. They provided smartphones to those patients very quickly, within about 1 or 2 days. The smartphones to those patients who didn't have them. These were 2 patients who didn't have smartphones. So the patients started their video observed treatment, but with their phones. But then gradually, MSF purchased smartphones for all our patients, and all the patients in our clinical study used those smartphones that were provided to them with enough internet package to allow for videos to be sent. So healthcare workers viewed the videos uploaded onto the Telegram channel, and this was a closed Telegram channel, closed access one, where the patient would upload his or her video, and it could be accessed only by our trained mid-level healthcare workers or doctors. At any time, they could view the video. They controlled. Doctors would control from time to time, but nurses viewed the video every day and would make a mark that the certain drug was administered in the records. So MSF provided all the technical supplies for video DOT, the SIM cards, and the traffic. And patients needed to sign informed consent and an agreement about the device they received, which they were supposed to return after the end of treatment. The video duty was quite strict. If nurses or doctors saw something that caused even the slightest doubt, we called in the patients when the epidemiological situation became calmer and more stable. We would call in the patients, invited the patients, and talks with them. And we also involved our psychosocial support specialists as well to find out why patients didn't take drugs. But there were also cases when we returned, when we stopped the video observed treatment and relaunched DOT for specific patients. During lockdown in March 2020, we started video DOT, 10 patients. Now it's a video supported treatment now, but back then it was video observed treatment. There were 9 and 1 woman aged younger than 60 years of age. I'll speak about other age categories as well. 8 MDR to XDR, 5 patients on standard, and 5 on research regimen. And we had a total of 42 patients on video observed treatment throughout the whole period of our implementation, 32 men and 10 women. There was 1 patient older than 60 years of age who was about 73 years of age. He was not, well, he couldn't use a smartphone, and we had to train his son to record and upload the video. Well, with this patient, we never had any problems. All the branch everything, he would upload the video on time, although we were concerned that this patient wouldn't be able to do this, but everything was fine. So standard regimen was for 20 patients, and research regimen was for 22 patients. 5 of the patients on standard treatment refused treatment, and we lost 2 patients during COVID. These were 2 patients with diabetes mellitus, both of them died because of COVID. They had to be connected to artificial ventilation, although they were almost at the end of their treatment for TB, and FT was actually going fine for them. But the reasons for refusal, treatment During DOT, two patients refused DOT, and Tashkent is a large city, they would have to travel, and they refused this outpatient treatment, and they would prefer their treatment at the local dispensary. And one of the patients was handed over to the dispensary for DOT because he violated treatment regimen several times, and we had to exclude this patient from the study and hand over to a local dispensary. And two patients considered that they recovered, and one of them was a doctor, by the way, and they refused treatment. Then they decided to no longer take the medicines. And one patient was lost to follow up, also from a socially vulnerable group, and because of adverse effects, two patients refused treatment. And they were on video DOT, and they did say that your drugs are making me feel very unwell, so we'll stop taking them. What are the conclusions that we can make regarding video DOT? In our case, video DOT improved adherence of patients treatment because patients were really afraid to start DOT and back to DOT and did everything on time. Our experience shows that the video DOT could be used in socially well-to-do groups and socially vulnerable groups. And also patients with comorbidities. We had patients with cancer and diabetes mellitus and other comorbidities, and they adhered well to the treatment. And this is also cost effective for the patient. They don't have to spend money to come for DOT to the clinic. And this helped us with DOT during the pandemic, and we didn't know what happens tomorrow and what pandemic could for us. Patients felt comfortable in their families at home. And when necessary, we did have experience with our patients, so we could ask family members to help their patients take drugs. And this is both observation that these patients are taking drugs, and they could help them with uploading videos as well. Amir also mentioned this, that there was a rapid communication from WHO that we can use these shortened treatment regimens, moxifloxacin and Bupal, and WHO recommends that they are used. And we're thankful to the Ministry of Health of our Republic, our center, represented by Nargiz Nusratovna, and also that this clinical study was initiated because this is, first of all, experience that we gain and an opportunity for patients to enjoy this innovative treatment. And Nargiz Nusratovna, please convey our gratitude to Professor Tilashaykhov, because when this was initiated, he was the director back then, and he also helped to initiate this. And we're very thankful to the sponsor for all the support that they provided in Amir. Спасибо за помощь. Especially during the pandemic, like to boast a little bit, none of the patients during the pandemic didn't miss even a single dose of drugs because we introduced the video DOT, and yes, the sponsor was helping us, and yes, we were organizing these field teams where the researchers and nurses would go and deliver drugs to the patients home. And without our sponsor, we wouldn't be able to do this. Thank you very much for your attention. I have questions. Ready to answer. Thank you, Rizila, very much. I know that you're very strict, and every patient knows that it's better that they take drugs on time than deal with you later. Oh, of course, I'm joking, but the team is very serious about their work, and Irina Vladimirovna and I do supervise them and request that the work is performed adequately. Dear colleagues, we're done with the presentations for this plenary session. People are pointing at their watch, probably they're already hungry, but we still have several minutes for questions and answers. These short questions, short answers. Yes, Sunatullah Nazarovich is in charge of our FCR department at our center. Microphone needs to be turned on.
I have a question to Emil. You presented serious adverse events for that BPL is higher, BPL slightly lower, BPL again lower. And I'm interested in how you manage those patients. You cancel the drugs, and then after you manage serious adverse events, you resume the therapy, or you switched to a longer treatment regimen. So thank you.
Thank you very much for the question. It was about safety and pharmacovigilance and safety management of the regimens. The basic safety management was to, record all the safety, serious adverse events and adverse events for all the regimens. And if a patient had a serious adverse event, which meant that they had to discontinue one or two of the trial drugs in the regimen for more than a 2-week period, then they would be discontinued from the trial. So it was actually quite a strict overall standard, but it was applied equally across all the regimens, BPAL-M, BPAL-C, and BPAL on its own, and to the standard of care as well. So it was quite strict for the trial setting, but it was applied across all the regimens. Thank you.
Спасибо большое. Есть еще вопросы?
Thank you. Any further questions? Yes, Nicholas. If I may, I have 2 quick questions about Karagal, Pakistan to Dr. Mo. So during your presentation, you mentioned that some of the patients were excluded from the cohort, those who received treatment less than 1 month. What was the key reason to exclude the patient from that cohort? And then percentage-wise, roughly, how many were excluded? And was that related to change in diagnosis? That's my first question. And my second question is, when you showed the success rates in 2020, it was the highest. And in principle, it also is similar to what the country level study demonstrated, country cohort. And my question is, when I was looking at the country cohort and your cohort, we are all aware that 2020 was the year of COVID. But anyway, we had high rates. And we do understand that these were the patients which were enrolled in treatment in 2018, and we were reviewing their results in 2020. But anyways, yes, they finished in 2020 and we got such good rates. Maybe we would like to hear from you what you think about this. Thank you.
Hello. Yeah, thank you, Nicola, for the questions. So before I answer to your questions, maybe I just want to quickly clarify about our data. So actually, our data is not a representative of the whole Pakistan. It only represents the data that MS has supported and MS has collected, like during our activity. So yeah, this can be misunderstanding if you look at as from the national levels. So in regards to your first questions, that's a very good one. And actually, that one is the one of the weakness of our database. And our database has the capacity that we can store the data throughout the years. And then since the patients who start the treatment for less than 1 month, according to the WHO definitions, it will be considered as if the patients come back for the treatment next time, it will be considered as the new cases. And then in order to save space for the database, and then it was decided since the beginning of the project to exclude those patients from our database. And we are aware of these challenges in our database, and we will work in improving the database in the future. And for the second questions, the treatment success rate for 2022 actually is for the cohort of patients that was recruited in that year, not for the patients recruited from 2018. So we calculated the patients who was recruited for 2020 and following them up until 2021 when they finished the treatment and calculated the treatment success rates.
Yeah, thank you.
Thank you.
Thank you. So just maybe for clarification, do you have any approximate percent of the excluded from the project?
We don't have that number.
Number, yeah, okay. Thank you. Thanks.
Well, thanks a lot for these excellent presentations. I would have a question to our MSF team representative. Dr. Moon mentioned that there were observed quite some resistances that emerged in the Karakalpakstan region, and we observed the same thing in Kyrgyzstan and Tajikistan. Can you mention or can you comment on potential reasons why these resistances emerge? In particular, what is your opinion regarding the co-medication of clofazimine with bedaquiline, since they share the same resistance pattern? And this is exactly what we, from the microbiology point of view, want to avoid, to combine drugs with the same resistance pattern or mechanism, because this facilitates the positive selective pressure of the emergence of resistance.
Thanks for the question. Can I ask actually Animesh to answer that question, because you have looked at that. I hope you got the question.
Thank you, Dr. Ahmed, for your question. It is quite interesting that we observe primary bedaquiline resistance even in contexts where bedaquiline has not been used. Similarly, in Uzbekistan, the incidence of primary bedaquiline resistance is pretty much similar to other reported studies in South Africa, in Russia, in Germany. The incidence of primary resistance, it's pretty much similar in Karakalpakstan. The acquired resistance is something else, which we are studying and trying to understand what drug exposure or whether patients are being given adequate number of effective drugs in their regimen, and whether that is affecting the emergence of resistance to especially to bedaquiline. Clofazimine cross-resistance, we can't really say much at the moment. After we have the sequencing in place, maybe we'll be able to understand better what proportion is due to mutations in RB0678 or due to other mutations, which might explain a bit about clofazimine and bedaquiline cross-resistance. So yeah, a lot to learn still, but we understand that there are challenges, and it's not new. I think in your presentation as well, you mentioned that anytime a new drug has been introduced for the treatment of tuberculosis, we have seen resistance emerging. That should not stop us from giving the best available treatment to our patients. I think that should be the take-home message, that what is the best treatment? Patients should be able to access the best treatment. We are here to save patients and not primarily to save patients and not primarily to save drugs. Yeah, thank you.
Thank you very much. Уважаемые коллеги, меня сейчас предупредили, что обед остывает. Поэтому
Dear colleagues, our lunch gets cool. And first of all, as hospital hosts, we have to feed our guests, and you have your lunch vouchers, and they say where your lunch will be served. Then at 2:20, you are expected back.
батон. Можно вас пригласить. Вот теперь работает. К сожалению, из всех своих софасилитаторов заявлено Таджана,
Unfortunately,
Андрей Махняги.
for all our co-chairs, I guess I'm the only one. That's why I asked Nicholas to co-chair. So we are having the plenary session resistant TB innovations and implementation. So the first message is overview of the European Laboratory Initiative for TB, HIV and viral hepatitis. So there is Sani, specialist in laboratory diagnostic, WHO Europe, Denmark. So then we'll be online. So good afternoon.
Good afternoon, colleagues. Good afternoon. Great to see you from remote.
Thank you. Please.
Am I going to present live or will you play the recording?
Just a second. Today we asked our technical support group.
Sure.
Она наоборот спрашивает, как, говорит, вам будет удобно, что делать? So actually there is, its choice is yours.
Okay, if the connection is good and if they can project the Russian slides, I can present online. Whatever works technically best.
Okay, I think you can do it online, and we will project your Russian slides.
Excellent.
То есть вы можете поставить слайды по-русски и... Okay, thank you.
Thank
Floor
you.
is yours, so then.
Okay, I just wait for the slides to be pulled up.
Ну, слайды по-русски есть у вас?
Excellent. Okay. I go ahead.
Just a second, waiting for the slides.
I wait for your green light.
Mm-hmm. Yes, I think we can. Yes.
Okay.
Yes, floor is yours today. We have our slides on Russian.
Thank you so much. Thanks a lot and good afternoon, all colleagues. My name is Sudhe Sani and I'm the laboratory focal point in the Joint Infectious Diseases Program at the WHO Regional Office for Europe in Copenhagen and Denmark. Thanks for the invitation and this opportunity to present to you today, and congratulations on this amazingly organized and very interesting conference. I very much regret that I was not able to be there in person. Throughout the next slides, I'm going to give you an overview of the European Laboratory Initiative on TB, HIV, and viral hepatitis, and its activities towards the implementation of the Euro-Regional Action Plan. Just very briefly on the history and background of ELI, which started in 2012 with the main mission. Just give me 1 second, there is a little issue from my side here. The presentation just collapsed. Okay, here we are back. The mission of the European Laboratory Initiative started back in 2012 with the support by the Global Laboratory Initiative, with focusing on strengthening TB laboratory capacity in the WHO European region and its 18 high TB priority countries. The platform serves primarily for experience and knowledge exchange to support countries in the implementation of the latest WHO global recommendations. And ELI further moved towards actively, previous slide, please. Thank you. Actively providing technical assistance to the countries by developing relevant guidance documents adapted to the region's needs and capacities by closely working with experts from the entire region. And as you know, we have a very heterogeneous region. We have some of the best worldwide known scientifically leading and research leading institutions and some of our high MDR burden countries. So Within ELI, we really try to build a bridge between the latest scientific knowledge and the necessities and capacities in the field. In 2018, ELI's mandate was further expanded to support not only TB laboratory capacity, but also HIV and viral hepatitis, with the focus on integrated lab services. And with this, the composition of the group changed as well. Next slide, please. Currently, the main focus of ELI is to support laboratory services in our 18 high-burden countries, TB high-burden countries, towards the implementation of the latest WHO guidelines and the latest Euro action plans. For this, we focus on all major elements that will lead to well and safely functioning laboratories that can be trusted to provide quality assured and timely test results for the patient's best benefits. So far, we have been supporting laboratories in strengthening their biosafety capacity and well-maintained and functioning equipment, implementation of the latest WHO recommendations on testing and algorithms, technical guidance in line with the WHO global recommendations on the country's capacities and needs, strengthening quality assurance beyond the annual EQA panel testing, and we trained human resources and moving towards integrated laboratory services and helping the countries in building sequencing capacities and the relevant strategies. Next slide, please. Regarding biosafety and lab maintenance, two of our key activities are listed here with the development of training materials with leading specialists in the field of biosafety and the support of ministries of health from 11 countries of the region, including all 9 high MDR burden countries and including Uzbekistan. We trained more than 22 engineers and technicians that were officially nominated by their ministries of health on the maintenance of biosafety cabinets. And as you know, biosafety cabinets do not only play a key role in providing a safe working environment for the laboratory workers, but also important for quality assurance, as non-functional biosafety cabinets can lead to contaminations. The provided trainings were all based on relevant international standards, such as the EN 12469 and the ANSI NSF 49 standards, both from a theoretical and hands-on practical aspect by leading specialists in this field. And we are extremely happy to know that one of the trained engineers from Uzbekistan is currently actively performing the maintenance of biosafety cabinets in Uzbekistan. This is really a big success for the country. Furthermore, we developed a comprehensive laboratory maintenance plan, both in Russian and English, which is one of the ELI's most used practical documents. It outlines clearly which equipments in the lab need what type of maintenance at which time interval, and clarifies the qualifications needed to undertake the maintenance work. In the majority of cases, the maintenance of the equipment on daily, weekly, or monthly basis can be done by laboratory workers. But in other cases, the work needs to be done by certified engineers or technicians. And with this, the document has also been very helpful for laboratory and NTP managers to be able to budget the necessary funding for laboratory maintenance. Next slide, please. Furthermore, the group has worked closely with the high MDR burden countries specifically on adapting their policy documents, such as their algorithms based on the latest WHO recommendations, through the development of regional diagnostic algorithm and relevant trainings. In fact, our last training regarding this topic or related to this topic was from earlier this week on discordant results between genotypic and phenotypic results. As we received also many requests on, next slide, please. Many requests on necessary to support and technical guidance on result interpretation for molecular diagnostic tools, both from the lab side, but also from clinicians. We have further developed and worked intensely on the development of an online training toolkit, which we launched in early 2020, that is being regularly furthermore updated ever since. The course has currently more than 25,000 active users from WHO Europe and beyond, in fact, from all around the globe. And the course exists in Russian and English language and is free of charge available on the open WHO website. Next slide, please. The course consists of 4 modules and a section on important updates and frequently asked questions. And it really provides the users with the fundamental understanding that is necessary in order to be able to interpret molecular diagnostic tools. Next slide, please. Furthermore, an online discussion forum is available on the website where users, again, both lab specialists, but also clinicians, can post their questions, including discordant results, and also follow other users' questions. The forum is regularly monitored by ELI experts and questions are responded. Additionally, questions can be sent to the ELI email address. And we are currently updating the course in order to add the entire spectrum of the classes of diagnostics that have been recommended in the latest guidelines. Next slide, please. Another very important component for quality assured and timely results is obviously related to quality assurance itself and finding standardized and comprehensive ways to perform full assessments on regular basis of especially laboratories that perform drug susceptibility testing. To this end, ELI has developed a comprehensive TST quality assurance assessment dashboard that will allow the assessment of all key steps that lead to the ultimate DST result. The tool was piloted in several countries of the region and further adjusted based on the piloting experience and feedback that we got. It comes both in English and Russian language, and some of you have already been trained and familiarized with the tool by our ELI and WHO consultant, Dr. Natalia Shubladze, that is currently in Uzbekistan with you, who has also played a key role in the development of this tool. Many thanks to her and her efforts for finalizing this important ELI milestone. Next slide, please. On this slide, I have listed some examples of ELI's work during the beginning and midst of the COVID-19 pandemic, including the first rapid communication on the use of GeneXpert for SARS-CoV-2 testing, various relevant training sessions and surveys, and the last survey that we published was on the DST capacity at most of the NRLs within the region that was published earlier this year, which you can access through the links that are provided. Next slide, please. Furthermore, given the expanded mandate of ELI and the lessons learned from the pandemic on the importance of integrated laboratory services, ELI has worked in 2 relevant publications, the latest one from earlier this year, in the relevance, describe the relevance, but also the challenges for integrated laboratory services on TB, HIV, and viral hepatitis and beyond. Next slide, please. Now, another technical area that was also discussed within the context of this conference and that was likely positively impacted by the pandemic is the increased interest for sequencing capacities. In fact, the World Health Organization is currently convening a guideline development group to analyze the use of targeted next-generation sequencing for TB diagnosis, and we're expecting the recommendations to be finalized and published by early to mid 2023. Next slide, please. Now, what we have observed often in several countries was the following scenario. The country received a high-throughput sequencing platform, often purchased through external donor funding, but with no clear sequencing strategy in place, both for TB and its potential for other diseases. And experience has shown that building sustainable sequencing capacities, especially in resource-limited countries, needs a well-defined strategy to ensure the necessary funding and capacity, but also the use of the platform in a cost-efficient manner. Next slide, please. And to this end, we are finalizing the development of a tool that is meant to help interested countries and partners to plan and build sequencing capacities based on the latest recommendations that we have on that, and based on the thought through and comprehensive strategy. We will be happy to share this tool soon with you. And with this, next slide, please. I will finish my presentation and thank you for your attention, as well as thanking our former ELI core group members, as well as the newly elected members of 2022, including Dr. Laziz Turayev, which is really giving us a great honor to have him on board as ELI core group and use his wealth of experience and knowledge to support Uzbekistan and the entire region. Thank you very much.
Thank you very much, Sudev, for the very interesting update. We would like to ask you if you have a time to remain for a while on with us online, because at the end of the session there might be some questions to you.
Dear Nicholas, I have in 6 minutes we will start another very important call with the ministry of one of the countries where we are performing a program review. That's why I might have to excuse myself, but colleagues in the audience will record all the questions and I'd be happy to respond via email. But if there's, we still have 6 minutes. If there's any question at this point, I'd be happy to stay and respond.
Yeah, then we probably will violate our rule and ask audience if there are any questions to Sudev, to ask them now that she is still with us and can answer.
Перевожу. Суде может с нами быть буквально несколько минут, и если есть у вас вопросы, можно задать сейчас, если есть быстрые вопросы.
So Sude is with us for another several minutes, and if we have quick questions, please ask them now. But Sude will be busy. But anyway, we have Isabella, we have Dr. Harold with us, and we have Laziz. And I guess they will be able to answer questions, if any. And let us thank Sude. If we have no questions, Laziz, do you have any? Laziz has the question. Well, you can come here if you want. Microphone. So then, thank you so very much for your presentation, and it is really essential for us that much attention is paid to laboratory diagnostics of TB in our countries, in high burden countries for TB. And getting back to your presentation, I have a question which is more technical. So much attention is given to biosafety cabinets, which have to be annually certified. Please tell us, in addition to these specialists who will be trained or are already trained in how to certify those biosafety cabinets, will there be any activities on procurement of equipment for certification of BSC? So what do you think about it? Thank you.
Thank you, dear Laziz, for this important question. And you indeed touch based on one of the bottlenecks that biosafety cabinet certification has. So one is to have trained engineers. The other one, as you said rightly, is to have the necessary equipment. And on top of that necessary equipment needs to calibrate it itself as well. And the calibration cannot just happen anywhere. It has to happen at a place where you can trust the calibration process itself as well. So you are absolutely right. And we know that Uzbekistan has at least a set of maintenance equipment, but its use is limited as far as we have understood. So indeed, it would be very much recommended to have the set of necessary equipment, but this needs to go together with the calibration capacities to be provided. So indeed, fully agree with you on that point. And both calibration and equipment for the maintenance need to be provided and ensured.
Спасибо. Если можно, еще один вопрос по поводу инструмента, который был уже.
Thank you very much. One more question, if I may, about the tool which was piloted several days ago in our lab. When
do you plan to officially present this very tool, and when we will be able to try to test that tool to assess the laboratory, say, in Uzbekistan?
I understood that the question is with regards to the DST quality assurance assessment dashboard. Is that correct? Yes, yes. So the tool has been, so what we recommend is for the first assessment, the first assessment should be ideally done by an independent specialized assessor. And afterwards, the laboratory should be trained in order to do self-assessments on regular basis. And regular basis means, depending on the outcomes of the first assessment, you will know in which situation the lab is, whether it should be reassessed or certain points should be reassessed in 3 months, 6 months, etc. That's what comes out of the analysis of the tool. Now, we have Natalia currently in Uzbekistan, and I understood that some training has taken place. And that was also one of the goals of extending her stay, to train at least the staff of the reference laboratory on using that tool. And you yourself as ELI core group member will also further be trained on that to be able to do the assessments in Uzbekistan and maybe hopefully even beyond Uzbekistan. And on the question of when it's going to be published, we are actually in the very end stage of having it published on the WHO website, and I'll definitely keep you updated on that.
Thank you very much.
Thank you so much, Desude, for your time and for your presentation and your answers, and wish you a nice rest of the day. And we say goodbye now to you. Thanks.
Thank you so much. Good luck, and see you maybe later. I can reconnect back in 2 p.m. Thanks a lot. Bye.
Bye. Так, уважаемые участники конференции, сейчас у нас выступает Кристиан Корнс, директор.
Dear participants of the conference, Dr. Christian, of course, will be speaking about the initiative of CEFID to strengthen partnership in Western Europe and Central Asia. Hello, Christian. Good afternoon. Can you hear me well? Yes, we see you and hear you well. Excellent. You have the floor. Thank you very much. I will share my screen then. Tell me if you can see the screen. Yes, we can see it, Christian. Okay, everything's working well then. Thank you very much for invitation. Thank you. My name is Christian Korns and I represent CEFID in the region. And I would like to express my sincere gratitude for the time that you allotted for me so that I could share the news about our work and what we're doing to strengthen our collaboration in the region. And of course, I'd like to express my special personal thanks to Nargiza Nusratovna and her team for the invitation to this conference and to speak at this conference, and my warm wishes to this big on this event, the 100-year anniversary of this pulmonology and physiatric activity. So I will move to the point of my speech. Briefly, in a couple of words, our mission is still the same as several years ago, is to improve treatment outcomes for patients, ensuring universal access to molecular diagnostics. You probably know the formula of the GeneXpert platform. It's been used for more than 20 years now in the region and globally to test for TB. And not only, and so they also spoke about integration. And to emphasize that, I would like to remind you that currently the platform combines more than 30 tests or is able to perform more than 30 tests, and it ensures accuracy, the speed, the flexibility, quality, and simplicity. So flexibility is one of the factors that I would like to speak about more on the next slide. Today, we speak a lot about patient-centered approaches to delivering care. So the possibilities of multiplexing using gene expert platforms help us to flexibly approach large spectrum of testing into all levels of laboratories. We can speak about reference laboratories and regional or district labs, or even microscopy, smear microscopy centers and points of care. I'm not going to go into details on the slide. So with regard to testing, I would like to show you a more detailed picture. So at the center, we can speak about testing in hospitals with a large flow of patients. So we do have solutions for these contexts, but we feel comfortable if we're looking at working on the level of primary care, polyclinics, ambulatory clinics, also at testing at pharmacies could be offered. We have good examples of that. We can also speak of mobile labs or penitentiary system, border crossing points, or refugee camps. So flexibility of the systems allows us to bring diagnostics very close to the patients, and this is happening globally, including our region. Briefly about the evolution innovations. I'm not going to go too far into the past, but let's start with 2010 and 2011. That's when we launched and WHO approved expert MTB RIF test for diagnostics of TB. And 2018, that's when we developed a more sensitive MTB RIF Ultra test. And 2021, we have expert MTB XDR Access Care. So I would like to speak more about these three key points on the following slides. And one of the points is also Gene Expert Edge systems that you can see here. And I'd like to explain to you what it is about and how it can help you combat TB. I have one slide that sums up our approach to innovations in TB diagnostics. And you all know that expert MTB RIF, which was approved by WHO in 2010. Then we developed a more sensitive MTB RIF Ultra. Currently, you probably know that MTB RIF tests are, the plain one is going to be discontinued, no longer will be produced, and we're fully switching to MTB RIF Ultra in May 2023. Going to happen. So the new technology that was developed in 2021 and received approval from WHO is it's a follow-up test after MTB RIF Ultra to test for drug resistance for second-line drugs. And in the future, or in the pipeline, there are two tests that will include diagnostics of TB as such, and resistance to rifampicin, and resistance to isoniazid in one test. I think that's relevant. It's a relevant problem in our region. There's mono resistance to isoniazid, and you can test it at the same time with resistance to rifampicin. Another test in the pipeline of TB finger stick that will test capillary blood samples. I'd like to briefly tell you about a Gene Expert Edge system that we developed for full patient-centered diagnostics. What does it imply? On the left of the slide, you can see a single module Gene Expert with only one difference. The difference is that it works on an accumulator, a battery, so you can bring the diagnostic capacity to the patient. And the second difference is that it has a tablet computer, not a standard, but just a tablet computer with a simplified interface for simpler use. Now, the approved tests for Gene Expert Edge are MTB Rev Ultra, also approved by WHO, and HIV test, the qualitative test, also pre-qualified by WHO. At the moment, we're working on HIV viral load. It's in the process of pre-qualification by WHO. The system does the same as your standard Gene Expert. The only difference is that you can bring the diagnostic capacities closer to the patients. And the third topic that I would like to speak about today, with your permission, is Cepheid Access Care. It implies focusing on support of the existing pool of equipment in the countries. So if countries had problems with investing, support, or maintaining the equipment and logistics, so we have developed Cepheid Access Care to address this issue. And we work with donor organizations, and we've been implementing this system for several years. So how does it look? It's an extended program of maintenance that was developed and launched in January 2019. What's the main difference? The key points is that there's a new way of financing the servicing of equipment. That means that we, ahead of time, identify the additional costs associated with cartridges to cover all these services. This is a comprehensive program that can cover the whole installed equipment base in the country of coverage, in countries that also diagnose both TB and HIV. So this markup in the price depends on the basic equipment or pool of equipment that is installed in the country. And most important point here, helps that Access Care offers. You as a country or NTP are the only service provider. I mean, you will have access to one service provider. You don't have to be concluding contracts with local representatives. You have direct contact to Cepheid, and the costs are covered through markup of prices for cartridges. So it's a turnkey solution. So this is coverage of logistics and import and export duties. And this also covers the travel expenses and accommodation expenses of engineers as well. And this system has been working successfully in 9 countries already. And now we're holding active negotiations in several Central Asian countries where we have good local authorized service providers where we can introduce this system. And by the end, I have a slide that shows the results of this Access Care program. This is a report from Uganda, where in a specific year, in the first quarter, they introduced or implemented the Access Care program. And by the third quarter, you can see the increase in the total number of tests that are performed, and the detection rate increased. But what is also important on here on the slide, you can see this number 117. This means the number of days before failure of the equipment. In February, when they launched Access Care program, we had 170 days before the repair. By August, we were able to reduce the number of days to 4 days. So we have engineers in the country. It depends, of course, on where health facilities with these machines are located, but in general, you can see the success, overall success of the program. This was my last slide, and I would like to thank you for your attention and ready for questions. Good afternoon, and thank you very much, Christine. This is Nargiza Nusratovna speaking. Now, I'm so happy that you found an opportunity in online mode to at least be present in an online format. We always look forward to seeing you. Thank you for your interesting presentation. Secondly, I think that if you have a little bit of time, and we can have other presentations and then have a discussion at the end. But if your time is limited, we can ask questions now. If possible, could we go against the rules and I could accept questions now? Well, then, okay, we'll do so. I'd like to ask our colleagues who has questions. Yes, Mikhail Wolik. Dear Christian, hello. I'm happy to see you. Thank you very much for your presentation. One question to you regarding Access Care program. Well, you've been working for several countries. Which agency concludes a contract with you for Access Care? Which organization represents a country? Thank you, Mikhail. Happy to see you. Unfortunately, cannot see you in person. So we conclude contracts with ministries of health, or one level lower under the Ministry of Health. That could be in CDC, like in some other countries, or NTB. But it has to be a government structure, of course. Thank you very much. Thank you, Mikhail. Yes, Christian. One more question. You did say that Access Care service enables the country has to pay a certain percentage. Could you tell us what's the percentage of the price the country has to pay for countries? Thank you very much for your question. Well, it's differs from case to case, from country to country. We look at the pool of equipment installed in the country, how many equipment are still covered with a warranty period, and which ones are covered by service contracts, and many tests are done per year. And based on these findings, we calculate the markup. As for percentages, it's hard to calculate, but I could say roughly $3 to $1 per cartridge. I understand that the larger is the pool of equipment is in the country, the more consumption of cartridges there is, then cheaper it is to pay for this markup. Thank you. Yes, exactly. Thank you. Yes, please.
Yeah, please go ahead. Thank you so much, Christian, for the presentation. I just have two simple questions. We've seen
seen the progress of subtype, and currently now we're introducing XDR, MTB XDR, and changing the system from 6 color to 10 color. And again, you're going to introduce MTB RIF isoniazid. So are you also going to change the system to more advanced, like from 10 color to another color, so that, because it's really moving rapidly. Some people just had the 6 color, then they're told to change to 10 color, then yeah. Then to my second question, one of my colleagues was interested on how we do waste management of the cartridges. Which is the best recommendation from SAP?
So if I can answer in English, if you don't mind. To your first question, we have switched exactly. That's a very valid question, from 6 color to 10 color. That is the newest technology that we have, and the XDR is working on it. So to calm yourself, it is basically, we are not moving yet to a higher level of channels. So the RIF INH, the MTB RIF INH test will be working on the 10 color technology. So this is why we are sort of progressively transferring all the install base to 10 colors. Also within the mind that the new test will be working on the 10 color technology. And to your other question, to the waste management, that is also a big question. As of today, of course, the official answer is that you should follow your local regulations, because the local regulations are very different from country to country and from region to region, and this is why CEPET cannot develop one unified approach to the healthcare waste or the cartridge waste treatment. But there are many solutions, and today also the Global Fund is working within the RSSH, yes, the Resilient and Sustainable Systems for Health program, are working on technical brief, as far as I know, which will be published, and with certain suggestions on the healthcare waste management. The problem is that some of the cartridges are containing the guanidinium thiocyanide, which might be more dangerous to treat or to utilize. But as of today, officially we cannot address one unique treatment method. Thank you.
Yes, please. Next is Harold.
Harold from Gauting. Thanks for your excellent presentation. I would like to know what you think about the developments regarding System 1. They stopped the service for JX Alert, and they offer now Aspect, but Aspect brings quite substantial costs for the country for the fees they need to pay, particularly when the number of tests is getting high. And do you think there is an alternative solution possible with electronic laboratory information systems? Do you export all information that you would export to Aspect also to the laboratory information systems?
Thank you, Harold, for the question. We do have exactly, because of this issue, because of the high costs of the System 1 and so on. We have addressed this also on the WHO level, and we are a part of a working group with another organization on the connectivity, which would be the interoperability, and it is a project that is managed by WHO and another organization I don't know by heart today, but I saw in the hall Ms. Dilaram Kasimova from Apt Associates, right? And we were discussing this a couple of weeks ago in Almaty, and I wrote an email to it. So I'm sure we can have an online discussion on this. There is a project going on with WHO involvement, but it is work in progress today. But we are working on solutions, other solutions apart from System 1. That's for sure.
Quickly comment on the laboratory information system. What type of information do you export to laboratory information systems? Would this include all information that Aspect would also get?
Yes, so obviously the technology of exporting the data is different. We would not be exporting, patient data or sensitive data. So that would be, only from the epidemiological point of view, only the results and probably some servicing or troubleshooting data for that. But any sensitive data will be remaining in the country and in the systems itself. I hope I got the question right, and I hope I answered it.
Yeah, so will there be any clarification more or any other questions? Еще вопросы в зале?
Any other questions? Well, Christian, thank you for your presentation. Well, getting back to Access Key program, will it be able to replace the old 6-channel modules to 10-channel modules? Will it be inside that package agreement? Thank you, Liz, for your question. I'm happy to see you. Currently, we are working on how to switch the database from 6 channels to 10 channels, and actually then the modules will be processed likewise, but currently technically we cannot do that because we don't have technical solutions, but soon that issue will be addressed. And definitely if you switch from 6 to 10 channels, that will be included in that software. Thank you. Any further questions? If none, then we will thank Christian. Once again, let us give him a big round of applause for his engagement, and goodbye, Christian. Thank you so very much, Christian. So, but Nicholas is ours. He's local, and that's why he is inviting you to Uzbekistan, not to Georgia. So you will visit Georgia as under another program, and you are expected here. Thank you. We will see you in sunny Tashkent. So thank you so very much. We would like to invite the next speaker, Mansam Benga, technical consultant, Lift2B project. We will have a presentation on PayPal implementation and scaling lessons.
Спасибо вам большое. Спасибо, Наргиза Nusratovna.
Thank you very much. Thank you, Nargiza Nusratovna, for this opportunity to share our experience with PayPal. Мне хотелось бы
reflections on the rapid communications that we had from the WHO. So because okay, if we look at the rapid communication of the WHO, we can see that it contains the 6 months treatment regimen, which is the BPAL and the BPAL-M. So, and these are things that we have been working on for a long time, and we have got already the success of reducing the treatment durations. So, but still there are other things into the rapid communications that we also need to consider. So, and if we look further, we know that still there is the 9 months treatment regimen. So, but here with a modifications that linezolid can be used instead of ethionamide on this. So, and we move further again and see that this was a recommendations which we have before, and it's still in the present guideline. So now these are mainly for patients whom we cannot treat with the 6 months regimens or the 9 months regimen. So still, we can see that, okay, we have got some success on reducing treatment, but still we have to do more because there are patients that really needs also for the treatment to be shortened. For example, this kind of patients who will still have the 9 months regimen or those who will have the 18 to 20 months of treatment regimen. So the evidence of the recommendations that we have in the rapid communication, so this was based on the studies that have been done, so which is the NICS TB and the ZNICS, and also the TB practical, and many things has been said on the TB practical. And as it's already mentioned, Uzbekistan has played a very vital role, in the TB practical, so which give us the results that we have today, and we are talking about them. So then, for the BPAL operational research that KNCB is conducting right now, so is based on the 2020 WHO recommendations. So, and this was the period when WHO has recommended for BPAL to be used on the operational research for 6 to 9 months treatment regimen. So, and under the LIFT TB project, so which was funded by COICA, so and implemented by TB Alliance together with KNCB. So, and this was implemented in the following countries that you are seeing in this slide. So, and Uzbekistan is one of the countries in it. So, and the primary objectives of the study was to assess the end of treatment outcome, so then to assess also the rate of serious adverse events. So, and for the secondary outcomes was to determine the time to sputum culture conversion, and also to determine recurrent rates of TB after 6 and 12 months after the BPAL treatment, and also the adverse events of special interest, which is QT prolongation, hepatotoxicity, myelosuppression, so optic neuritis and peripheral neuritis. So the eligibility criteria that we used was based on the recommendations of WHO, so which was which is pre-XDR, so which is the recent recommendations that can be used by WHO. So then, based on the exclusion criteria that we use, we modified a little bit. So, and the modification that we have done was based on the recommendations of having 2 weeks of bedaquiline treatment or 2 weeks of any of the components that are in the regimen. So this was the WHO recommendations, but we decided to change that to 4 weeks based on the fact that there are so many countries which are using some of these drugs, and patients has already been treated with some of them within a short period of time. So that to include those patients altogether, we make this modification. So, and in Uzbekistan, so we are working together with the Center for Phthisiology and Pulmonology, so on the operational research which is going on now. So, and the following regions are covered, so which is Samarkand, Fergana, Andijan, Bukhara, and there is also plan right now to move to Kharazm Oblast. So, and the current status of the BPAL operational research, so into the different countries. So in this slide, you can see that the number of countries that we have, and also the planned number of patients that were planned for each of these countries. So then the enrollment period and the enrollment date. So, and the status of each of these countries right now. So, and the interim success that we have from each of the countries. So what lessons do we learn from the BPAL operational research? So we learned that, okay, we can have good early treatment results among completed cohort patients. So we have 85% of treatment success. So that was based on the partial cohort that we have. So we understand, so okay, the importance of cooperation at the national level, so the regional and global level of interest and involve the partners that we should work in. So we also understand the importance of utilizing international experience and the sharing of experience between countries. So, and the generation of evidence and the importance of adequate safety monitoring. So also understand that there should be enough capacity, that's adequate capacity of DST to enroll on the BPAL and the BPAL. Yep. So now, what are we doing presently based on the rapid communications that we have? So presently for KNCV, so we are providing technical assistance with the countries that we are working with. And we started with the update of the documentations that we are using. And this include the generic BPAL, so the clinical guide, and also the training materials that we use. So, and also during the operational research, so we are gathering all the questions that are coming in from the different countries and different research sites. So, and we are developing this into a frequently asked questions, and those ones will be used to support the countries during the programmatic implementation. So, and what are the roadmaps that we plan with the countries? So, and you can see that for countries, you know that, okay, right now they are having their operational research ongoing. So for those countries, we will work with them and complete the enrollment to the operational research patient cohort. So we'll support all the patients throughout to treatment completion, and we'll also support on the completion of post-treatment follow-up, and also ensure that there should be complete data collection, then the cleaning of the data and the validations. So, and also we'll write up the results and disseminate those results. So then, but still, if by the time we also have the WHO recommendations and the guidelines, if they are out, so we can also parallelly work with countries on the programmatic implementations in this case. So, and for the countries who are not having any BPAL operational research going, so the plan that we have with them is that to start with advocacy at all levels. So then we can disseminate the rapid communications and the clinical guide, or the consolidate guide and the operational handbook if they are out from the WHO. And we are expecting that maybe at the fourth quarter we'll have it, but still there are some doubts about that. So, and we'll raise awareness and involve stakeholders, treatment committees, and patients support. So we'll also work with countries to develop a cost on BPAL, BPAL-M introductions and the rollout, then help on the support of funding mobilizations on the procurement of the drugs. So for the preparations and training and implementations, and also work with countries to update national guidelines on also job aids and training curricula. So for the countries to also plan and prepare themselves, so it is good to have the background information of the DRTB epidemiology. So, and this will include resistance to fluoroquinolone, so bedaquiline, so, and linezolid. So we know that, okay, maybe pretomanids still there are some DST pending. So, and also have a forecast on the drugs and also diagnostic supplies that will be needed. So patient management. So, and here considering that the patients will have 7 days of treatment, so how this will impact on the healthcare workers who are providing also the treatment for the patients during this period. So the regulatory framework, so to work with the regulatory authorities that we can update the national policies and guidelines, so and work for the approval through ethics committees and so. So and for the administration, it's good to develop the implementation plan. So the identifications of the treatment centers and have meetings with those centers and also the key opinion leaders who are making decisions on that. So then we continue with the capacity building. So and in this case, we'll assess all the initial sites, so which includes the lab for clinical and both microbiology. So human resources capacity, so training of all the staff at the national level and also at the implementation site. So then also work with countries to provide support to implement and strengthening the ADSM. So and also have update on the monitoring and evaluation. So it includes the recording and reporting system, and also if there is a need of adjusting the database for that. So, and in this case also, when we are supporting on the implementation, we also understand the importance of patient-centered care and also the difficulties that patients are encountering, also traveling to the health facility, also taking their dots going every day. So and in this case, for us, we are planning also to introduce an adherence support system. So and the adherence support system, so we'll be using a digital health tool, so that will support patients at their own homes where they will be able to take their medications, and also those will be informed to the healthcare system. So and so here we are planning to introduce the smart toolbox. So because this is a box which you know that it has all the medications can be put into this box. So and the box itself remind patients on when they are supposed to take their medications. So because it also has a sensor, and that sensor, whenever the box it's open, so it gives automatic updates to the healthcare system. So which means that the healthcare worker, so for example, the doctor or the nurse will get a notification that, okay, this box has been opened. So and the patients will take their medications and they will record a video. So it's the same as VOT as patients used to do. So which means that then if the healthcare worker get a notification that the box is open, so then the healthcare worker will automatically have to wait and think that, okay, very soon I'll receive a video from a patient, so that I'll confirm that the patient has already taken this medication. So and oh, sorry. So then if the healthcare worker received the notification, so the notifications already come. So and this also simplifies the work of the healthcare worker. So because they don't need to enter all the information. So if they receive the video, so by looking at the video, so they will be able to confirm that, okay, the patient has taken the whole dose of these medications, and everybody will be, everything will be green. So confirming that the patient has taken the medication, which is a very simple step they can use. So and about the box itself, so the box has a life, okay, it has a battery which a lifetime of 6 months, and 36 months of worldwide data service that can be carried anywhere if the patient needs to go or travel somewhere. So and the chips that are in the box can be used for more than one patient. So and also the price is very cost effective. So the other thing that we also think that is part of the patient-centered care that we can introduce is about ECG monitoring, so a way of decentralization of ECG. So this is a project that we are running right now in Kazakhstan, so because we are doing a pilot project on ECG monitoring. So this is a small device called Cardio Mobile. So this device was approved by the FDA. So after it was tested during the coronavirus period. So because the device was used to monitor QT prolongations on coronavirus patients who were taking cardiotoxic drugs. So, and the device is wireless and it has a Bluetooth where that the information of the ECG can be transmitted to a smartphone or a mobile device. So it allows the recording of 6-lead ECG. So, and it has three electrodes. So, and if you can see it here, so in this green thing, so those are the electrodes. So the patients will put their 2 fingers on top. So, and underneath, either they will put it on their knee or they will put it on their ankle. So, and based on this, so it will record the 6-lead ECG. So, and based on that, the patients will send the ECG to the clinicians, and the clinician will make an evaluation. So the device itself and the app, so will also give a preliminary evaluation. So based on the ECG that has been recorded, but we need a confirmation from the medical worker. So, and also it's has a low cost and also very easy to use and simple, and it can be used by all the patients. So presently in Kazakhstan, so we have been using this device, and patients, we are recording their own ECG and sending it to the healthcare worker. So, and the other thing also that we give it to the mobile groups. So, and the mobile groups also were using this ECG. So, and the results that we have were very welcoming. So, because we also have a comparison of the device also with the conventional ECG. So, and we are right now working on the finalizations of the data, and very soon we'll publish all those information. Yeah. Thank you very much. That was all what I wanted to share, and will acknowledge all my colleagues, so, and our sponsors on this. Thank you.
Thank you very much. Thank you very much, Dr. Benga, for the interesting presentation, and I guess there will be some questions later. Следующая у нас выступает Наталья.
Next presenter is Natalia Shugadze, laboratory consultant, WHO Regional Office for Europe. And the presentation will be titled Towards Ensuring Quality of Tests for Drug Susceptibility with the Help of a New Tool. Natalia, you have the floor. No microphone. Good afternoon, dear colleagues. Some have seen me in the morning, so I'd like to say hello to you the second time. In this presentation, I'm representing the European Laboratory Initiative that Sudhi Sani told you about, and this is a tool that we jointly developed. It took several years, and it is designed for assessment of laboratories, covering mainly the technical aspects of labs. We hope very much that the use of this tool will help laboratories to improve themselves between different kinds of assessment, quality assessment and external assessments, and help them progress in their activities. As we know very well, the pillar of everything in TB control are the TST test results. This is a key parameter for correct choice of treatment regimen, for treatment monitoring, and for treatment success. For all this, we need correct and timely DST results. For this, a laboratory should strive for ensuring high quality results. That means that all the rules need to be followed and all controls need to be used to ensure the quality of test results. It's best if a laboratory is accredited into ISO 15189. That's the best option, but for some laboratories, it's too early to speak about it, but you can start this journey at any time. So it is very an important part of this process is control of the process of that is controlling what is happening in the lab and quality indicator monitoring. Process control is what we monitor from sample collection to reporting a test result. Pre-analytical, analytical, and post-analytical phase controls. But the main responsibility of the laboratory is, of course, the analytical phase. And for it to be performed correctly, we use quality controls. Inside tests, and these are internal quality controls. So whatever was written down on the slides, that's quality control. So quality controls are everywhere, just general quality controls for laboratories in general, and for each test individually. They need to be collected. They need to be monitored on a monthly basis. This needs to be visualized as a chart or a diagram. You discuss the findings with your personnel. You have to post them on a very well visible place to discuss it with your personnel, and then you document each your steps. So if there's an outlier with regard to controls, then you have to take corrective actions or preventive actions to stop this from happening again. In order to organize this whole system, we came up with this tool of ours, which need to help us to evaluate the performance of the lab, identify its weak spots, and provide a uniform. Well, you see, it highlights the answers. So actually, from the answers that you have in this tool, you can develop recommendations for improvement and filling the gaps. And we try to standardize the information that is collected by the tool so that this process can be continuous and frequent as needed by any lab. This is how the top, the title page looks. It's in an Excel format. I will try to show it. Oh, it's so inconvenient, but it has a short instruction, a user instruction. Okay, I can be standing there. I'm short-sighted. It's too far from me. Oh, well, anyway. In addition to this short user instruction, let's look at it here. There's also so-called big user manual, which has detailed discussion of all the questions. Down here, you see the tabs, and you can access them from the first page. They start with an algorithm, which you see it in green, and up to control of contamination, it's in black. Let's move on further. So now, that's DST is not an isolated process. It all starts with an algorithm. We might have an algorithm, we might not have an algorithm, or we might have it, but it's not approved. Well, that point is important because the algorithm tells us what patients to take samples from, because without an algorithm, this tool is not going to perform well. The second important point is measures of ensuring quality or quality assurance, both on the level of a country and on the level of the laboratory sites. Well, here it's the second tab of the tool. So we ask whether the country has a team at ministry or department or NTP that is responsible for quality assurance in labs. Have a manager for quality of equipment, by safety officer, and others. Then this tool, we ask you the following thing. We start asking about initial diagnostics tests, since this tool was developed for the European region. So the focus was on MTB-RIF, but we also added ultra. The next diagnostic tests, the hind test and expert XDR that was recently added. Then we collect sample collection. It's very important. And I would like to say this rejection rate less than 1%, sample rejection rate. This is what every country needs to have as a goal. I'm not the first one to say this. Everyone says this, and those who speak from the Tribune, we need good samples, quality samples, so that we can say that we're using the right adequate samples for our tests. Then there's a list of drugs that are used and treatment regimens used in the country. And if the laboratory is doing these tests for these tests, we're not happy with two options: when the lab is doing tests for drugs that are no longer used, or it doesn't do DST for the drugs that have been added to the treatment regimens. And finally, we have a list that goes through the DST procedure as such, both on solid medium, because many labs use it as a backup if they don't have test tubes or other supplies, and also on liquid media. This is very well described in the questionnaire and also in the user manual that is attached to the tool.
Currently, English version is fully ready, Russian version is expected soon, and we try to combine several techniques, and also we collect and analyze the performance rates, and they are analyzed automatically. So you see, this is the user manual. That's how it looks like. After designers have nicely worked on it, the same version will be available in Russian when you open it. For each question it says now, and then there is explanation why it should be now, and also there are links to various useful materials, including templates for SOPs and other documents you may need. And the results are unified, and you can come up with this same assessment in your lab from time to time, say once every 6 months, and you can track your own progress. I also want to show you that the answers are highlighted. So if it's yes, if it's a correct answer, well, sometimes no can be a correct answer. So if your answer is correct, any correct answer will be highlighted in white. If you have minor issues, then there will be yellow highlight. If it's a big problem, then you will be having the pink highlights. And then you will immediately see what needs attention when you just take a look at the questionnaire. Mostly technical status of the laboratory is assessed relevant. So to what extent you comply with SOPs, but managerial aspects are also included in line with requirements of ISO 15189. That's how The final result looks like you see the chart and the areas highlighted red to green. The red zone means that special attention is required, a lot of support is needed, and the green area shows that you better improve it, but mostly support measures are required. Next to that, you will see the table, which contains the same information, but using numbers, you will see how many correct answers you have and percentage-wise in the total progress. In case NRL and peripheral sites, well, they have different functions and responsibilities, and the level of responsibility is different. And for that, we split the level, central and peripheral. So you can answer one of those. Also, several languages are supported, currently 2, English and Russian, and you can switch them on the first page. On top of the page, you have the button, you can hit it and change the language. This slide shows the evolution of our questionnaire, the famous one, which has been in place since 2018, if my memory serves me right. So it all started with 266 questions. Back then we had 7 pages, and we also had other pages, and we also had the turnaround time, the biosafety. It all changed. So version 2 has 308 questions, version 3 409, and versions 4 and 5 have 573 pages, and we changed the pages, and we also introduced contamination control instead of biosafety, because for biosafety you have dedicated tools which carefully consider it from various standpoints. And here you can see the evolution over time, and I do hope that for someone it will be useful. What we can voice as conclusions, as advice, so regular assessment helps you maintain a certain level of compliance. And if you see some elements are missing, say monitoring of quality indicators, you just introduce it, do it for yourselves. There is no need for someone from the ministry to come and say, you please introduce it. It doesn't matter if you want it or not. So first of all, the laboratory needs it, so they could be sure that they do whatever it takes, so their results could be of high quality. And one more important point, please discuss with your personnel the results and remedial actions and preventive actions, because staff is the most important thing you have in the lab. And thank you for attention. These are the additional materials. This is not the full list, and I hope your labs will be the best in the world. And this is our email, and if you have any questions, please email them. Thank you. Natalia, thank you so very much. You've been in our country for some time, and in fact, Natalia stayed in the lab. She kept all the time. She kept training and sharing experience with our personnel. And I like your technique. On site, jointly with our colleagues, you are reviewing processes, you identified some challenges, some gaps, and you help them. Thank you so very much for what you have done in Uzbekistan. And you wished us the best laboratory in the world, but well, I have counter wish jointly with you. Thank you, Dr. Parpiva. This is a unique opportunity. Thank you for your confidence. I hope soon it will translate into reality. Thank you. Thank you so much, Natalia. Thank you very much in Georgian. Dear colleagues, if you remember yesterday, we changed the order of our presentations. Leona Skragina was replaced with Marian Dashov because he was supposed to leave the country. And now we will take this opportunity and instead of presentation by Marian Dashov, we will have a presentation by Alena Skragina. So Dr. Skragina is she is staff of Scientific and Practical Center for Tibetan Pulmonology, Minsk, Belarus, and she is a consultant also for WHO Regional Office for Europe. Please, technical team, let us hear her record. Good afternoon, dear colleagues. First of all, I would like to thank you for your invitation to participate in your very important conference on this wonderful occasion and share experience in using shorter regimens for rifampicin-resistant TB in Belarus. While speaking about introduction of shorter regimens, we all understand that first of all, we need to have an opportunity to quickly diagnose and adequately diagnose rifampicin resistance. And if we compare it by years, then we will see to what extent over 10 years use of GeneXpert increased in our country, and use of LPA. And if you take a look at this very section below, you will see that the appropriate time for a diagnosis for the patients in the Republic is 10 days. And so over this period, we use GeneXpert, LPA, and BACTEC. And if we do so, then we will know the resistance pattern, because it's essential to quickly find out if there is resistance, if we want to early introduce adequate treatment, well, without adequate diagnosis, it is next to impossible. And then the preconditions for introduction of shorter regimens include TB concilium. This is our Republican concilium. Each province has its own concilium, and you see that it has various functions. And you are aware of that because you also work as part of the concilium in each and every country, and you also have a national provincial level concilium, and you can see that the first item here is prescribing treatment regimens in line with WHO recommendations. Why I did so is because concilium is the tool which makes it possible to prescribe the treatment which is currently missing in the national protocol, but which maybe has been used in some other countries. Maybe it is WHO recommended, or maybe the country decided to conduct operational studies. Another important precondition to introduce shorter regimen. Could you please volume up? Well, since 2012, we have gained extensive experience in pharmacovigilance, so we also use it for HB HIV cohort, and then very poor sound. We apologize. All this time we were providing full-fledged treatment. I'll skip the details, but I guess you understand the data collected monthly prior to the start of the treatment, and then all information goes to international database. So the recommendations could be developed on this basis later on. The preconditions for STR implementation. So in our country, starting 2016, we introduced video-supported treatment, video-observed treatment. So these are data as of September. So 2,600 patients overall were on VOT, and our experience here is presented, and you see the manual digital technology, which is also shown on the slide. And the whole chapter here is on Belarusian experience in using digital technology. Why it is so essential? Because we understand that shorter regimens should be administered daily, even on holidays, on weekends, and that's why it has to be administered daily. For shorter regimens, this is essential. So when in August 2018, as you can see here, we have issued that document. So rapid communication was issued by WHO about the operational research. So WHO encouraged such research, and after that, relevant recommendations were provided, and major changes were known back in August 2018. And so in line with WHO recommendations, our NCP, without further delay, developed those shorter regimens. And you see this regimen is well known because almost the same regimen is one of the most prevalent or modified shorter regimens in US. Almost all countries are engaged in that. When we were writing our protocol, well, 24 weeks is the only difference for bedaquiline. As for other drugs, well, they were used for 9 months, and only bedaquiline was used for 24 weeks. And after approval, we actually started the research where 220 persons were
около 6% это сахарный диабет, каждый 10-й имел гепатит С, видите, чуть меньше процента.
So you see the percentage slightly lower, and 5% in cases of diabetes mellitus. So these are the risk factors. So every third patient was alcohol user, and 1% drug users, 1.8% unemployed, and 13.5% of patients had lower body weight. And as for the process, for patients enrolled in the first country cohort, you can see that 35% were positive on microscopy, smear positive, and also some half had monolateral bilateral processes, and you see the percentage of those without destructive processes. And if we compare effectiveness of our first country cohort for shorter regimen, so again, here we have the regimen, which is different compared to currently used regimens. The bedaquiline is used for a shorter period. I've mentioned that before, 24 weeks. Well, the treatment success rate is 90%. And if we compare it to the overall country cohort, then back then, the treatment success for that country cohort was 76%. And here you can see the rates for other indicators. I mean, for those which are considered to be favorable outcomes, death plus to follow up, treatment failure, and also you can see the benefits, which are definitely there for shorter regimens. And then the WHO initiated the regional study for modified shorter regimens, and Belarus quickly stepped in July 2020. Our generic protocol was adapted in Belarus, and after that, it was approved by WHO ethical committee. And in November, the first patient was enrolled because in that period we failed raise funding, and part of the patients was not enrolled starting December 2019 and October 2020. Well, actually, we finished enrollment of the first cohort and it became retrospective and starting 1st of November. Well, we had the regular cohort and plus we finished so in October 2021, and then we continued with prescribing shorter regimens. You are aware that overall we had 137 such patients, and in total, all the patients that received in Belarus modified shorter regimen currently total 727, 550 represent provincial cohort, and 127 is the number of patients in the country cohort. You see that every third patient was previously treated with second-line drugs, and 80% males. So the great number of patients was 30 to 59 years of age. You see that the comorbidities are prevalent in the same manner as in the first country cohort. These are patients who have, in 7% they were diagnosed with HIV, 10% with hepatitis, diabetes mellitus, it's a bit lower, about 4%, a bit of hepatitis B, 1.7%. So the risk factors are alcohol abuse, 37%, about 8% of drug users, homeless, 3.9%, and 17.9% with underweight. Since this cohort was collected at the end of 2021 during the COVID time, there are more patients who had Temur conversion. According to microscopy, 41% were diagnosed more than the first cohort. For us, it's an unusually high percentage when we speak about microscopy. About the same number of patients with unilateral and bilateral. Now, effectiveness of treatment with shorter modified regimens. See, you can see that the effectiveness, retrospective and prospective, regional cohort of 550 people was 88.4%. In the second country cohort, since they're on treatment 76%, we cannot now evaluate the treatment success because there's a small number of patients. So we need to make sure that everything goes well. In 2018, we started the clinical study. There were 3 arms, one BPAL, one BPAL plus oxyfloxacin, and BPAL clofazimine. You see that 10% were HIV infected people, considerably fewer with diabetes mellitus,
it just turned out this way. And to be practical, there were only 70 people. There were a lot of patients with diabetes mellitus. There were 13.6%. 1 in 5 patients have abused alcohol, and they were also underweight patients. 18.2. Bilateral damage was in about 20% of patients. And look at treatment success. Treatment success for these patients was 85.7%, because the protocol is very strict, and we had to exclude 10 of them. But we were inspired by this because the treatment regimen is very short. As you know, it's only 6 months. So starting in February this year, we started an operational study, SMART. At that point, we didn't have rapid communication, although we showed that BPAL plus BPAL plus MOXIE could be used in broad practice. That is not going to be an operational research. And you see that currently we have included 276 people who are either on BPAL plus MOXIE or BPAL plus clofazimine. And we're planning that by the end of the quarter of this year, we will start a programmatic implementation of BPAL and BPAL-M. So, how did the country introduce shortened regimens? We started in 2018 when only 2.8% of patients were on shortened regimens. In 2019, it was 1 in 4 patients. Well, look at October 1st, because patients enrolled in September for a shortened regimen were included into this number. There were 78% of patients with rifampicin-resistant TB were enrolled either for MCDR or BPAL. These are apples and other fruits and vegetables from my garden, squash and pumpkins. These are my pets at home. All our program, anti-TB program in Belarus, congratulate you on our excellent anniversary. With this slide, we would like to say that all of us are very well ripe and ready for short treatment regimens, which are easier for patients to tolerate, which are effective, which help them to go back to their normal lives. And we would like to share that we are ready just like you are. We'll thank Alena, although this was a recording, so Alena is unable to hear us, but Alena is usually the one who at the end has very interesting photos which are close to her heart, and she shares that with us. This is the evidence, is that she doesn't spare her knowledge and share this. She's ready to share this information. She's a very open person, and she would come to our country as well, and we met her in different countries. And in the future, we will thank her in person. Next presentation is online, as far as I know. Sandeep Juneja, Senior Vice President of TB Alliance, or maybe somebody is going to speak instead of this speaker. No, she will be doing it herself. We'll speak about cost effectiveness of regimens containing pretonamide.
Какой-то пацан, блин, начал на меня.
I'm Sandeep Juneja.
Добрый день, я Сандип Джунежа, я старший вице-президент Market Alliance.
And congratulate Uzbekistan for 100 years of TB services in the country and for 90 years of scientific activities of the Center of Phthisiology and Pulmonology. The success of Uzbekistan in reducing TB incidence over the years and improving many epidemiological indicators of TB provides a very good context for my presentation about an innovation that could potentially further improve the country's response to tuberculosis. But before I start my presentation, I'd like to briefly introduce my organization, TB Alliance. TB Alliance is a United States-based nonprofit that is focused on discovery, development, and delivery of new TB treatments. We developed the new drug Predominate to be used in combination with bedaquiline and linezolid, or what is called the BPAL regimen, that for the first time reduced drug-resistant TB treatment to the same duration as that for drug-sensitive TB, that is 6 months, and with similar success rates. Apart from Predominate, TB Alliance has in its pipeline several novel drugs in various stages of development, and we are aiming at further improving TB treatment with these new drugs. In my presentation today, I'll share with you top-line results from studies and analyses for understanding acceptability, implementability, and cost-effectiveness of Predominate containing regimens. So when TB Alliance was relatively confident on clinical viability of the BPAL regimen back in 2018, we wanted to understand if it will be acceptable in the field. Will it be implementable? Will it be cost effective or cost saving? And what would be the likely usage of the regimen? We conducted research to answer these questions in diverse countries representing different geographic regions, that is Southeast Asia, Sub-Saharan Africa, Eastern Europe, and Central Asia. We considered countries with low and high burden of TB and low and high incidence of HIV-TB co-infection. There were multiple studies we did. One was a study to evaluate acceptability and feasibility of the BPAL regimen. Another was on cost effectiveness of the regimen. And yet another one was on estimating savings and analyzing budget impact of implementing BPAL. Research collaborators across these three studies were KNCB, London School of Hygiene and Tropical Medicine, and Johns Hopkins. I will now talk to top-line results from these studies very briefly that have all been published between late 2021 and early 2022. The first study showed high level of acceptability for the BPAL regimen on 7 parameters such as patient friendliness, programmatic implementation, human resource requirements, patient support, etc. It was found that while the regimen was rated similarly as longer treatment regimens with respect to need for patient monitoring, it was rated nearly twice versus the standard of care in terms of patient friendliness and was about 1.5 times higher in terms of ease of programmatic implementation. Overall likelihood of implementation in pre-XDR TB was rated as 88%, giving us confidence that the regimen will likely be accepted and implemented by countries. The two costing studies at a very high level found that BPAL will result in notable reduction in both cost of medicine and cost of treatment monitoring. Depending on the country, medicines cost in case of pre-XDR TB may reduce by $4,000 to $6,500, and total cost of treatment may reduce by $6,500 to $11,000 per person treated. In terms of percentages, that means that the overall cost reduction could be up to 80% for the total cost of treatment. We know tuberculosis, especially drug-resistant TB, exerts a very heavy toll on an individual's daily life. Relapses, treatment failures, extended treatment duration, and poor tolerability of regimens results in loss of healthy years from a patient's life. Given shorter duration of BPAL, its success rate in studies, and relatively lower side effects, and manageable side effects, we were interested to understand potential impact on disability-adjusted life years, or DALYs. Per modeling done by the team from London School, DALYs are estimated to reduce by well over 50% for BPAL when compared to standard of care for pre-XDR TB. I've included links to all these 3 studies and publications in the last slide of this presentation, and they are all open access. As you know, BPAL in combination with moxifloxacin is part of WHO's rapid communication. Hence, we were interested to understand potential for cost saving of the BPAL-based regimen in MDR-TB as well. We worked with WHO Global Fund and Stop TB Partnership to estimate potential savings for use of BPAL and BPAL-M in almost all MDR-TB. Our estimates show that potential health system savings for using the BPAL or BPAL-M regimens could be up to $740 million if they were implemented in all MDR-TB patients or almost all MDR patients immediately. Of course, that will not happen that fast, but this does show the potential savings possible with these regimens. On total cost of treatment basis, BPAL and BPAL-M will result in 40 to 75% savings for MDR-TB patients and up to 90% for pre-XDR TB patients. This benefit is in addition to substantially reduced pill burden, shortened treatment duration, and improved success rate observed in clinical trials. Other than cost modeling analysis and studies, we are also conducting real-world cost effectiveness and budget impact studies among patients who are enrolled in South Africa's BPAL Clinical Access Program and operations research that is underway in the Philippines. Results are expected by early next year from these studies. In addition, we are developing a costing model in collaboration with the Swiss Tropical and Public Health Institute. This can be used by any country to calculate their own cost effectiveness and budget impact analysis on deploying the BPAL and BPAL-M regimens. The model should be ready by end of the year or early next year. And if you'd like to use it, please contact my colleague Asta Gupta, whose email appears on this slide. Finally, we are working on long-range projections for the use of BPAL and BPAL-M in collaboration with Stop TB Partnership, WHO Global Fund, and KNCB. At this time, we are interviewing several high-burden countries to build those projections in a scientific manner. If you'd like to help us, please contact us, whether me or my colleague Asta Gupta. Again, her email is mentioned on this slide. Thank you, and with that, I'll be happy to take any questions that you may have.
Thank
you very much for the presentation. That was interesting. Right now, we will listen to another presentation. Salah Faraida is going to speak as he is a Senior Medical Director from TB Alliance. And his presentation will be on clinical news on the use of predominant combination with Daquilin and linezolid and the BPAL regimen in drug-resistant TB. Здравствуйте всем, меня зовут Сала Фарида из TB.
Dedicated to the discovery, development, and delivery of TB drugs. Today, I will be presenting an update on pretomanid in combination with bedaquiline and linezolid, or the BPAL regimen in drug-resistant TB. In today's presentation, I'll be covering 4 topics: the next TB trial, the ZNext trial, TB practical trial, and the WHO rapid communication that came out May of this year, 2022. I'll start with the next TB trial with the BPAL regimen. So the next TB was published in the New England Journal of Medicine, March 2020. We recruited 109 participants with either XDR or MDR-TB using the WHO definitions of XDR before 2021. And the results from this study showed that 90% of all participants had favorable outcome, which means 90% had clinical and bacteriological resolution 6 months after end of treatment. In March of last year, 2021, at the Congress for Retroviruses and Opportunistic Infections, we presented the 24 months after end of treatment follow-up for all patients. So all patients were followed for a full 24 months after end of treatment. And actually the efficacy, the high efficacy of 90% was maintained 2 years after end of treatment. The second topic will be the XENIX trial. And the idea of XENIX is with the very high efficacy that we observed in NIX, there was adverse events mainly related to the high dose that we used in NIX TB trial. So in NIX TB trial, the linezolid dose was 1200 milligram once daily, which is a high dose of linezolid. And because of this high dose of linezolid, the 1200 milligram, we observed with the high efficacy, we also observed adverse events mainly driven by the high dose of linezolid. 81% of participants in NIX had peripheral neuropathy, and almost 48% of participants in NIX had a myelosuppression or anemia, bone marrow suppression. So the idea of XENIX was to investigate if we can maintain the very high efficacy of 90% that we observed in NIX with a lower dose of linezolid to improve the safety profile of the regimen. So the XENIX trial was a phase 3 partially blinded randomized clinical trial for arms. Bedaquiline and pretominid was not blinded. However, the linezolid dose and duration was double blinded. So these are the 4 arms that we investigated in XENIX trial. And by the way, XENIX trial was published last month, September 2022, in the New England Journal of Medicine. So we recruited XDR patients, pre-XDR and MDR patients, randomized into 4 arms. The 4 arms are, the first arm which is similar to NIX, 1200 milligram of linezolid for 6 months, or 1200 milligram of linezolid for a shorter duration, 2 months, or half the dose, which means 600 milligram of linezolid for 6 months, or both lower dose and shorter duration, which means 600 milligram for 2 months. These were the 4 arms investigated of XENIX. The duration of treatment was 6 months. The primary endpoint was 6 months after end of treatment, which I will be presenting today. And the full evaluation of the trial will be 18 months after end of treatment, hopefully to be presented next year or so. Bedaquiline dose was once daily, and this is to allow for fixed dose combinations in the future with pretominid. The primary endpoint was both clinical and bacteriologic status 6 months after end of treatment, which I will be presenting today. Favorable outcome means cured. Anything else, whether clinical failure or bacteriological failure or relapses or any alternative treatment, withdrawals, any death will be considered unfavorable in the XENIX trial, similar to NIX. You can see the full inclusion criteria on clinicaltrials.gov. However, we recruited males and females, 14 years and older. In some countries like Moldova or Russia, the age was 18 years or older. Participants who had XDR, pre-XDR, or non-responsive or intolerant to MDR TB treatments. And here again, I'm using the definitions prior to 2021, which has changed in 2021 by the WHO. You can also see the full exclusion criteria on clinicaltrials.gov. However, the main idea is to exclude patients who may have resistance to the regimen components, and also excluded patients who have previous exposure to bedaquiline, linezolid, or delaminate for more than 2 weeks to reduce the possibility of having resistance to any of the components of the regimen. In this study, we recruited 181 patients from 4 countries, South Africa, Georgia, Russia, and Moldova. And you can see here, we're randomized in the 4 arms of different linezolid dose and duration, 45 in each arm. So 45 or 46 in each arm of the linezolid dose or duration. Here are the baseline characteristics. 2/3 of participants were males. 20% of participants were HIV positive, and also the majority had either XDR or pre-XDR TB. This is the primary efficacy analysis modified intent to treat population. And as you can see here, the total, the overall efficacy or favorable outcome was almost 90%, which is very similar to what we observed in NIX, 89.3%. This is very similar to what we observed in NIX. And this is ranging from 93, 88, 90, 84, all arms of linezolid dose or duration were effective, as you can see, ranging between 84 and 93%. The total was 89%. This is the favorable outcome, and the unfavorable outcome was 10.7 or 11%. So 19 patients out of the total number of 181 had unfavorable outcome. These results are very similar to what we observed in NIX. The time to culture negative status, the median time was 6 weeks across all 4 arms. So if you can see the 4 arms with a 1200 milligram for 6 months or 2 months, or 600 milligram for 6 months or 2 months, the median time to culture negative was 6 weeks. Slightly delayed with the arm that used 600 milligram for 9 weeks. The 3 adverse events that are related to linezolid or of special interest were, as you know from NIX, was peripheral neuropathy, optic neuropathy, and anemia or myelosuppression. And as you can see here, the total was 25%, which is way lower than we observed in NIX. In NIX, it was 81%. This reduction is mainly driven by the lower exposure to linezolid, whether shorter duration or also lower dose, 600 milligram compared to the 1200 milligram. The optic neuropathy, which is a serious adverse event, the 4 cases out of the 181 were all in the 1200 milligram for 6 months. And 0 cases were in the other arms. And thankfully, all these 4 patients completely resolved when we stopped linezolid. Also, if you look at participants with worsening grade of anemia, you will see in the 2 arms using the 600 milligram lower percentages with worsening grade of anemia. A percentage of participants who needed modifications to linezolid dose, and modifications include interruptions, reductions, or permanent discontinuations. And if you look here, the 2 arms who used the 600 milligram dose needed the lowest modifications of linezolid dose. And the highest percentage was with those who used the high dose of 1200 milligram, whether for 6 months or for 2 months. So the conclusions coming from Zenix trial are we observed the high efficacy of the BPAL regimen as in NICS across all 4 arms. And we think that lower adverse events will be associated with lower exposure to linezolid. The 1200 milligram linezolid for 6 months was associated with higher peripheral neuropathy, and all 4 cases of optic neuropathy were actually in this arm, thankfully all of which resolved when we stopped linezolid. And when we did the risk benefit analysis, it suggests that the 6-month 600 milligram regimen is the most favorable regimen among the 4 regimens. I'm now switching to the 3rd clinical trial, which is TB practical trial for MDR. As you can see here, this is not only XDR or MDR TB, but it's for all at least rifampicin-resistant TB. So any drug-resistant TB, not just highly drug-resistant strains of TB. This study investigated 3 regimens, BPAL regimen for 6 months, or BPAL plus clofazimine for 6 months, or BPAL plus moxifloxacin for 6 months, compared to the local standard of care for MDR-TB as a control. The study was 2 stages. In stage 2, there was a decision to proceed with the BPAL plus moxifloxacin for 6 months to be compared with the local standard of care. This study was sponsored and conducted by MSF, or Doctors Without Borders, and the linezolid dose was also similar to Zenix, 600 milligram for 4 months, followed by 300 milligram of linezolid for the remaining 2 months. Now switching to the WHO rapid communication that came out in May of 2022. So the WHO reviewed the evidence coming from Zenix and coming from TB Practical. And the conclusion was the BPAL regimen and the BPAL plus Moxi regimen, or the BPAL-based regimens, showed high treatment success and actually expanded from XDR to any drug-resistant TB. And almost all people with drug-resistant TB could be treated with this 6-month oral highly effective treatment. And I'm saying almost all people here to exclude patients who are below the age of 15 and the WHO rapid communication, and patients who may have resistance or have resistance to components of the regimen. And these two regimens are BPAL or BPAL-M. Conclusions from the WHO rapid communication is BPAL-based regimens, BPAL or BPAL-M, almost all drug-resistant TB patients, and this is could be done under programmatic conditions. The previous WHO guidelines in 2020, 2 years ago, was recommending the regimen under operational conditions only. So this is a change as well. And also the linezolid dose is now optimized and suggested to be initiated as 600 milligram once daily instead of the previous recommendation of 1200 milligram once daily. So the new rapid communication is 600 milligram once daily, initiate on this dose. And also there was some concerns about the reproductive safety of rituximab, and you can see in the WHO rapid communication of May 2022, the evidence has largely alleviated the previous concerns on male toxicity observed in rats and mice studies. Special thanks to all participants who enrolled in the clinical trials, to all investigators and site staff, funders, and many partners and collaborators, and also to the alliance donors that you can see in this slide. This is my email. Please feel free to reach out anytime if you have any questions related to this. Thank you so much.
Thank you very much, Dr. Salah Farida, for your very interesting presentations about NICS and XENIX trials. Остались две презентации.
We are having 2 more presentations, and we would like to ask Oleg Russkих. He is the head of the Department for Physiology, Ijevsk State Medical Academy. And we will hear from him about possibilities of pathogenetic therapy in improving effectiveness of treatment of patients with TB. Dear colleagues, I'm Oleg Russkих. I am head of TB department. Ijevsk is a city in Russian Federation, so where Fyodor Tchaikovsky was born, Kalashnikov, and also Buranov's grandmothers, grannies, which won Eurovision. And first of all, dear Nargiza Nostratovna, I would like to congratulate you on this wonderful anniversary. Yeah, I've noted that many people celebrate 100th anniversaries, 90th anniversary. In Tatarstan, they also had that huge celebration of the 100th anniversary of Tatarstan service, plus the medical academy. Congratulate you on this very occasion. And hopefully this cause where you invest all your soul and efforts, because you see, yes, for 2 days you've been sitting here, and this suggests the highest level organization of this very conference. And all your knowledge and experience bring happiness and necessitate further professional achievements. And this is from our rector, and actually this is my 3rd time at your activities, and I hope I will keep visiting you. Well, switching to my presentation, a lot has been said today about etiologic therapy, and definitely this is the fundamentals for patient treatment, but let us focus on the second element, pathogenetic therapy. Let me move a little bit. And dear colleagues, please take a look. WHO clearly identifies indicators for treatment success for MDR and TB patients. So you have to treat at least 75%. And actually, as that's for MDR and TB. As for susceptible to be at least 85. So what's happening? In reality, based on data from WHO and our leading experts in the Russian Federation, we can see that globally the treatment success for MDR and TB patients is 48. In Russian Federation is 51. But yesterday, in presentation by Dr. Varpieva, I could see the treatment success for MDR and TB in Uzbekistan was 67%. Am I right? So this is very high. That's using traditional techniques as for innovative techniques. That was 89. So you see that. So you complied with WHO requirements. So which are the main factors which currently deteriorate success? So are aware that this is the increased number of patients with MDR experts. Adverse events as a result of combined anti-TB treatment, and we all know that any TB drug has some adverse events, and many patients just don't want to continue treatment. They reject treatment, and failure to comply with the treatment regimen, so default and comorbidity when there are several conditions, including HIV infection and Weinstein. What are the additional factors? Well, currently we have limited selection of drugs with evidence-based anti-TB effects to treat MDR, XDR TB patients, and the range of drugs changes slowly, so they slowly emerge in our lives, but they show up. And the duration of treatment is up to 2 years, although today actually shorter treatment regimens have been introduced. But anyways, the duration is quite long. So the working group new TB drugs continues research.
New drugs are being researched, also the older drugs and the new and coming drugs are going through post-marketing research, but 1 in 4 TB patients are also have TB and HIV. And when it comes to MDR, 1 in 4. So TB-related epidemiological situation is quite tense. In 2017, there was a grandiose event in the Russian Federation. That was a ministerial conference, the global one. So from around the world, ministers of health came to Moscow to address these questions. So what do we do with TB and how do we stop it? And one of the SDG targets by 2030 was to end the epidemics of AIDS, tuberculosis, malaria, and other diseases. And it is interesting that the Russian Federation was actively involved into this process and set the goal to reduce incidence and mortality by 90%. And TB doctors may be left without the work to do with these goals. And we know that treatment of tuberculosis is a comprehensive one. This is both chemotherapy, surgical treatment, and recently a number of surgeries is decreasing, but this method should be treated as one of the main methods of treatment, and there are other methods as well to treat TB. We should say that currently we see that physical TB treatment methods are really effective. Inhalation therapy is one of them. It's being overlooked, but I see that Fatima Kudratuna is actively engaged into inhalation therapy, and her presentations were dedicated to using different ether oils, or essential oils, to achieve very good results. Methods of natural physiotherapy are important. For example, treatment at sanatorium and health spas, and there are 25 to 30 sanatorium in Russia which offer services to TB patients, and also the staff of TB care facilities to go there and strengthen their health from the southern Crimea to other parts of Russia. Also, nutrition, therapeutic nutrition of patients is important with increased number of proteins in nutrition in the Russian Federation. Well, they are fed very well. There are no complaints about it. No, like now, like as compared to before, psychological health is important because the stress that TB patients face, first of all, it weakens their immune systems. So there should be very well streamlined psychological assistance at the Russian TB facilities. There's one department that is dedicated to provide psychological support to TB patients to withstand this chemotherapy regimen that is quite difficult. Two, parts of therapy, pathogenetic therapy, and etiotropic therapy. Etiotropic therapy is the leading type of treatment. Rudoy Nikolai Mikhailovich in 1969 pointed out that rational chemotherapy, which we're discussing now, prevents development of drug resistance in the pathogen. The pathogenetics and pathogenic therapy are very closely related to each other, and they influence the processes of progression of the disease, processes of healing, and can improve the qualities of etiotropic therapy. So here are the possibilities of pathogenic therapy. It influences all pathogenesis parts, so you need to reverse the pathogenesis so that there are fewer sequelae and side effects of the treatment of TB. We should say that in the Russian Federation, treatment of TB patient follows clinical recommendations approved by the Ministry of Health of the Russian Federation. There is a clear description of chemotherapy, and the authors of new clinical recommendations dating to 2020 focused a lot on pathogenic therapy. So it shows a non-drug and drug-related treatment of pathogenic therapy. And it should be pointed out that the possibilities of pathogenic therapy with all types of TB are present, no matter what form is present, whether it's latent TB infection, the new TB case or secondary TB case. You can use different methods of pathogenic therapy. Again, huge groups of pathogenic drugs are described, and they're actively used in treatment of TB patients as pathogenic means of treatment. But currently, there are adjuvant drugs which help with difficult etiotropic therapy in organizing the treatment. What is adjuvant therapy? It is a host-directed therapy which is added to the main etiotropic treatment and is necessary and is a recognized approach in TB treatment. Adjuvant therapy is available in all areas of medicine, including oncology. It strengthens the protective capacities in any human body and improves the effectiveness of treatment. So among all adjuvant drugs, the classical adjuvant therapy drugs are Blutoxin. It's widely used in the Russian Federation, and it's also used in the Republic of Uzbekistan and other countries. Why? Because it has a broad spectrum of action. When I analyzed this drug, I saw its action, and there's an interesting property that it has: activation of apoptosis processes. Apoptosis is a self-destruction, programmed destruction of cells, which leads to progression of processes, diseases, and aging. And Glutoxin helps to reverse an inflammatory process and resuming of apoptosis. When I was preparing for this presentation, I looked up the clinical effectiveness of Glutoxim as a drug in TB practice. And there are a lot of clinical studies, and main ones were conducted in St. Petersburg, Moscow, other clinical centers, and just a few of them. This is a research study from St. Petersburg. They analyzed TB patients who were on Glutoxim and chemotherapy, and the second group of patients who didn't receive Glutoxim. And during 3 months, as we can see, patients who were receiving Glutoxim, this group stopped excreting bacteria. Now, another proof of effectiveness of treatment is managing intoxication. So when Glutoxim is used, intoxication patients stopped earlier, and that helped them to better tolerate the main drugs, and that helped them to continue the treatment. And also you see how infiltrative and needles of infection in the lungs took faster to heal. So Glutoxim has a good detoxifying effect that helps to restore the detoxification function of the liver. We'll skip that in this. How do we use this? There's an instruction. It's used in the formulation is in vials and used for 10 days. 60 days or 6. And in conclusion, I'd like to say pathogenetic means in physiatrics are necessary drugs when you treat a specific TB patient to improve effectiveness of treatment or success of treatment, and for good tolerance of chemotherapy. And the use of adjuvant drugs for pathogenic therapy helps effective strengthening of protective properties of a human body in the TB patients, and leads to quicker cessation of bacterial excretion. Thank you very much. Well, we have the last presentation by Nikonenko Boris, and the presentation will be about efficacy of anti-tuberculosis vaccination depending on the genetics of the host. Experimental study. Dear colleagues, I represent purely experimental work that was performed in the laboratory of immunogenetics at the Central Immunology part of Central Research Institute of Tuberculosis in Moscow in Russia. We used the lines of mice that were either bred or supported in the nursery of our lab at our institute. I have two parts. The first part is efficacy of BCG vaccination depending, emphasizes BCG vaccination depending on host genetics. Well, the relevance of the problem is that genetic control of susceptibility to or immunity against the new infection is quite well studied, both in humans and especially well on experimental model on mice, laboratory mice. Genetic control of vaccination with BCG is not well studied, especially in humans. And I cannot even imagine how you can study that in humans. At our lab, we earlier showed that mice of congenic lines, H2 lines, these are histocompatibility lines, they're well vaccinated with BCG except for one line, which is beta and H2F. Also, mice apply CBAN, which are different. So one mutation in their chromosomes are not vaccinated well with BCG, not at all. This speaks for separate genetic control of susceptibility to a new infection and genetic control of vaccination with BCGs. There are very few works that research works that confirm this hypothesis. Now, the objectives of our study were to estimate the efficacy of BCG vaccination in mice of different inbred lines and compare the efficacy of vaccination in highly susceptible line I strong with other strains, lines of mice, then evaluate the role of H2AP gene and compare the vaccination efficacy in mice inbred lines to non-vaccinated AKR, YST, F1, and B6 and I. Also, examine the resistance in mice which are highly resistant to infection. We need an efficacy to microglobulin knocked out mice. They have H2 molecules of class 1. Here we show mice strains which were used in work. The first one is strong. These are the highly TB susceptible. Out of 60 to 70 studied strains. This defect of susceptibility to TB infection is not related to any immunodeficiency. It's purely a specific defect which is not manifested in response to other mycobacterial infections. Mice of 6 lines these are mice that are resistant to TB infection and mice strains 100 and 139 are different with only allele H2A the allele J that determines the susceptibility and allele B that determines relative resistance. Okay, Strong's is the most resistant strain of mice. If some time ago we started studying a strong line with high level of infection intravenously, and strong mice lived for 3 weeks, 20 to 22 days, and hybrid F1 lived for 120 days, and colossal difference. Mouse strains knockout with microglobulin. On these strains of mice, we focus. Here we show the differences in these two congenic strains, not for the whole locus of the gene, but only for the locus that codes beta chain. The methods of study vaccination of mice subcutaneously 10 to the 6th degree of CFU, infection of the viral strain MTB-H37RV intravenously or in an aerosol form in a chamber or glass coal. And with that, we assess the survival rate of mice. We used a graph prism to build histograms of survival of mice. And we also did bacteriological culturing from lungs on solid medium. This is the dynamics of survival of mice. It's difficult to grasp everything from this graph. But let me just say that here, eye-strong mice who were the most susceptible on the left curve. And vaccination with BCG insignificantly strengthens resistance to the disease and insignificantly extends the survival of these mice. The most right are mice like 6 vaccinated with BCG or hybrids F1 nice strong not vaccinated BCG. They are so resistant to TB infection that they don't require vaccination with BCG. Here, it's about the same. Black cells and eye strong for comparison. The most left is eye strong. Black cells are vaccinated and non-vaccinated, and hybrids F1 and black cells are strong, and their survival rate is comparable with others. This is even more complex histogram showing or bar chart showing the survival of mice. As for mice, again, hybrids of F1, AKR nice strong. They survive as long without vaccination as any of the most vaccinated mice. And here, vaccination of mice knocked out for beta-2 gene microglobulin. The knockout of the part of gene leads to very strong decline resistance of mice to TB. As we see that mice heterozygotes with one MO plus started dropping. These are normal mice. Vaccinated mice can live up to those. Here is the growth rate of mycobacteria from lungs and spleen of mice after 3 and 8 weeks of infection and tuberculosis. B6 and non-vaccinated, B6 vaccinated, F1 affected by virulent strain.
Мыши невакцинированные F1 высокорезистентные выглядят не хуже, примерно так же, как вакцинированные мыши БЦЖ. Мыши Black 6, вакцинированные БЦЖ. Это как в селезенках, так и в легких. Здесь через 3 недели и через 8 недель тенденция одна и та же. Ну, значит, на основе этих результатов такие сделаны выводы. Эффективность вакцинации БЦЖ у мышей зависит от выбранной инбредной линии, то есть она разная. Эффективность БЦЖ вакцинации у чувствительных к туберкулезной инфекции мышей у мышей чувствительных к туберкулезу, более чувствительных, более эффективна, чем у более резистентных. А это исключение составляют мыши айстронг, которые самые чувствительные, но вакцинируются они плохо. То, что касается конгенных рекомбинантных линий 100 и 139, они чувствительны и резистентны по-разному к инфекции, но вакцинация БЦЖ продлевает выживаемость и тех, и других мышей на 127%. То есть эффективность вакцинации в данном случае не зависит от аллеля J или B, от которых зависит резистентность к первичному заражению. И мыши любых линий вакцинированной БЦЖ не достигают или не превосходят резистентности невакцинированных, высокорезистентных к туберкулезу гибридов F1, которые, ну так получается, что они в вакцинации этой и не нуждаются. Ну и по бета-2 микроглобулину тут все понятно. Второй этап исследования – это создание и изучение вакцинных свойств нового атенуированного штамма микобактерий туберкулеза. Значит, цель была создать новый штамм микобактерий туберкулеза с использованием подхода, который когда-то использовали 100 лет назад Альмет и Герейн, для создания БЦЖ из вирулентного штамма микобактерий боvis. Для этого мы использовали вирулентный штамм H37RV. Методика такая. Вносили по 0,25 мл микобактериальной суспензии, 25 мл среды 7H9 и культивировали в шейкере при температуре 37 градусов в течение 2-3 недель, до появления мутности. Затем вот это небольшое количество 0,25 брали и переносили в 25 мл свежей среды, и так повторяли очень много раз, сделали всего 70 таких пассажей, и конечный образец назвали туберкулезис BN, с использованием инициалов автора. Дальше посмотрели, а как этот штамм влияет вообще на мышей. Ввели внутривенно 10 в 6 мышам iStrong, самым чувствительным промежуточным BALB-C и резистентным Black6, и БЦЖ, или этот штамм. И наблюдали в течение года. В итоге все iStrong мыши и там выжили 100%, BALB-C то же самое, и Black6 умерла лишь одна мышь через 8 месяцев после введения БЦЖ. То есть это какой-то артефакт.
So the attenuated strain as BCG doesn't show any pathogenicity, and as for genetics of this very strain, so that was done in the laboratory by Professor Nikila, Institute of Bioorganic Chemistry. So 8 single nucleotide insertions and deletions that distinguish the strains were identified. They are listed there, all those genes. And as for other differences, they are not listed here. And we failed to find mutations in genes of the locus AX1 or D1 of those regions. And actually, those are the regions associated with virility, and it means that it doesn't look like RB and doesn't look like BCG. So here is the bacterial load. So in lungs and spleen, 300 days after inoculation, in mice, L6. So no particular difference between the load for BCG and for attenuated strain has not been seen. The load is not high. This is histological, pathological changes. So no significant pathological changes were found 300 days after administration of BCG took like 6 months or attenuated strain. Also, no changes were identified when strong mice received it, again 300 days after. This is an illustration. Well, 50 days after inoculation of the virulent H37RV strain to like 6 mice, so the image is totally different. Vaccine properties of this strain. So subcutaneous vaccination, mice valve C, we can see that the survival curve for mice who received BCG and those who received the vaccine strain, they almost match. And so for BCG in this model and for this strain, we can see that the survival of the mice is increased. This is inhalation vaccination with attenuated strain. This is shown in blue, so this is way more effective than BCG. Here we see the trends in body weight of the mice compared to the previous slide. So the blue line controls, and by day 80 you see the reduction. So this is almost the start of their demise, and those mice that received the strain, well, for them this process has yet to start. And as for intravenous vaccination, well, yes, the preference is with the strain, but statistically the changes are not reported. Well, we have few mice, so we have to repeat that experiment. And as for mice that didn't receive BCG, well, CBAN and CBA. Well, the black columns here. Okay, we'll get back to the black lines. Yes, survival rates for mice. Here you can see that B10M were not immunized. This was CBAN. This is the table intact. CBA and CBAN have almost the same survival rates, and following vaccination, CBA survival increased considerably and CBAN has not. And we did it even before. So as far as CBAM mice, we identified that it was linked to mutation in chromosome. This shows how the vaccination strain affects the CBAN mice survivability when they are infected with the vaccine strain. So the controls and those who received BCG, they match those curves and no particular effect. And for others, you see that the survivability has increased considerably, so BCG is not working, and the strain is working quite well. And here we have vaccination of eye-strong mice, and they get vaccinated better with the strain, and this is visible. So interim conclusions at this stage. So the new attenuated strain has this vaccine potential at the level of BCG or better. So the new attenuated strain protects microorganisms from TB in some genetic systems where BCG doesn't work. And also let me add that we also worked using other strains, and as for TB resistant or interim, actually the result is almost the same. And if there are some defects or lower level of resistance, then it works even better than BCG. And actually a new strain allows to study the causes and mechanisms of BCG failure. Because as shown before, when BCG is given to mice, then neutrophils get accumulated and the effect of vaccination is reduced, and currently there is study in progress of immune response to the introduction of attenuated strain. The experiment with mice B10M has started not vaccinated with BCG. Also, there are experiments, comparative testing of attenuated strain, which were not used before, and then there are experiments on interaction of MTBVN strain with intestinal microbiota of mice. So for intravenous administration, I can tell you that the strain doesn't violate the microbiota balance. And so strain passage continued, and we will continue our analysis of genetic and vaccine properties. I believe that we will come up with a totally different strain, and the results for some of the experiments are preliminary. And we need to repeat the experiment, and we need to carefully analyze it. Thank you. Thank you so very much. In fact, that was the perfect piece of research. And as I said before, during Atajan Ergeshevich's presentation, the Central Research Institute for Tuberculosis has way more advanced science and innovations because you have different capacity, and we wish you every success. Hopefully you will make us happy with new vaccines and some other initiatives and research findings. Thank you so very much. We have finished this session. And maybe anyone has questions to our speakers. Do we have any? Everyone got tired. Just 2 days. Only 125 presentations. Why are you tired then? Really would like to ask Sherali Sherikbayevich, please invite all others who finished their satellite meetings. All those who stand and tell us that, well, this is like the contest of witty remarks, and since Call for Primary Professionals is still in progress, well, let us wrap up our 2-day conference. And with Nicholas' permission, I will first present my conclusions, and then I will hand it over to you. For 2 days, we have worked quite fruitfully, and Vera, will you inform us on the total number of participants? You haven't counted them yet, but after that, we will send this information to you. And I can tell you that 2 days, we have participated at 7 plenary sessions, 9 sessions, 6 schools, and 3 satellites. I guess for 2 days, that was quite intensive work. And actually, we heard 125 presentations, messages, and I'd like to thank everyone, all speakers, first of all, participated offline and online. I would like to thank all of you for this high level of presentations, because I guess you will agree that all reports were interesting to the audience. And jointly with Nicholas and other co-chairs, I've been sitting here. Well, since I'm the head of the department, and I always look in the eyes of those sitting in the hall, and I could see interest in your eyes. And that's the key result of our 2-day work, because the objective was to commemorate the 100th anniversary of the service and 90th anniversary of our center, and also in memory of academician Limov, we wanted to organize scientific and practical conference, not just to recall our experience and to honor our veterans, but the key objective was to share new knowledge and new findings with all our colleagues. And I repeatedly mentioned, and I keep insisting on that TB doctors are members of one big family, which is global family. We could hear participants from the US, and Melzer could participate, and it was 6 a.m. on her side, but out of respect for us, for our conference, and she's a stylish woman. Anytime. And you see, her presentation was so good, so interesting, so much new information was presented, as well as those presentations. So regardless of the country we live in, we are addressing the same problem. We are combating the deadly infection, which is airborne. And you know what? When we look back at the COVID-19 pandemic, I keep saying, yes, COVID is dangerous, and that's the pandemic which quickly spread. And at the same time, we had positive lessons learned. First of all, for us, for TB doctors. Well, actually, now I have a very strong point to convince the highest levels. People who are very far from healthcare, you see what an airborne infection is, which spreads quickly. Yes, COVID is transmitted faster than TB, fortunately, but I warn everyone that if we reduce our attention to TB, TB is not COVID. You can treat it within 2 weeks. At least it will take you 6 months. Well, I'm saying 2 years, actually, to make it more convincing and to frighten them, and actually requires a lot of investment. This is the burden on the economy of a country, and that's why
received another factological base, evidence base on how dangerous droplet infection can be. And we can state the level of our online communications, our online speeches, because before COVID, we didn't have that. And now we have excellent presentations. The technologies maybe in a forced manner, but did develop. And and that also leads to the progress in video supported treatment. Still, we learned lessons, but I'd like to remind you that COVID threw us back a little bit. Because there was no opportunity for diagnostics like we have now. Our clinics in many countries were reprofiled into COVID centers and so on and so forth. And globally, we have COVID-induced diseases. It's a very well-known disease, but the provoking factor for these well-known diseases was COVID. Back in the year 2020, the head of the Stop TB Partnership announced that we're increasing a growth in post-COVID TB. And truly, at our center, we do see quite a number of forms of generalized TB, quickly progressing forms of TB in patients. And of course, these 2 days of the conference were a great platform, an excellent platform for us to exchange knowledge, experience, and skills. And I would like to once again thank the participants, everyone who took part for very active involvement. I would like to thank our donors, and special thanks go to them, to USAID, to MSF, to Global Fund. Am I forgetting anyone? Correct me if I'm wrong. Shanoff is showing that all those organizations that help us to demonstrate the newest technologies that are presently available now to us. I would like to thank them for technical support. Please take a look at the wonderful conference rooms that where we held um, uh, our event, and I hope that you like lunches and coffee breaks, and I hope that everyone satisfied with us, and we're helpful. We're thankful to our partners for organization at a high level. Special thanks to our two interpreters. Ladies, we love you very much. I'm always amazed at your wonderful pronunciation of all the terms and drugs and dosages. And soon, but you'll be saying them better than some of the specialists. And we wish to take part in these positive events in the future as well. And I hope I'm not forgetting him. Well, I'm not forgetting. I left it for dessert. I would like to thank our team that I've bothered so many times for a long time, and I'm immensely grateful for you that you actively made a contribution to everything, and everyone, all our team members are here. We're one great big team. That the team is the right word for it. It's practically a dream team. But inshallah, I don't want to jinx it. You cannot relax tomorrow now that you have set this tempo. You have to follow it. Thank you very much, Nicholas. He's all ours now. And Nicholas is inviting Christian to Uzbekistan and Georgia because he is now a permanent resident now here. Nicholas, you have the floor now. Thank you very much, Nargiz Nusrat. I will try to be brief and I will not repeat myself because we've heard a lot of interesting things of messages were of high quality, and there was a great number of them. There were representatives of the TB service this country, also doctors from regions traveled to Tashkent. Probably not all of the TB doctors who work in the country were able to come here, well, there are many more of them. There are also nurses who work locally. There are also junior clinics that will work there. I would like to congratulate them all as well with this anniversary event. And I would like to wish them professional success and well-being and peace in their families. I think that firstly, we felt the high level of political support from the highest levels of the government that enables us to be here and does not give the opportunity for the National TB Center to lead here. This is happening under the leadership and guidance of Nargiz Nusrat, and we're so thankful to her. And she did mention the team, and I do congratulate the team. And I would like to point out the cohesion of the team. And Nargiz Nusrat played a big role in building this cohesive and effective team. Now, who else could be pointed out that the technical team who was helping us all this time, and our operators, photographers who felt when to capture the right moments, and we felt like celebrities when we were photographed. Thank you very much. Thank you all. Someone has a desire to come up here and speak, we can do so. Well, Nicholas, and there's a lot of technical staff when this young man was coming up to the camera and correcting it. I even felt sorry for him. And we have an excellent photographer who captured all the episodes and even very small fine aspects of our conference. And we also share the link on YouTube with information on about our conference and presentations. And those who order photographs and these photo messages, we hope that we'll be able to post the information there on the web, and you will be able to find yourself on YouTube. Is there anyone else who would like to speak? Well then, thank you so much. Katta rahmat, and I hope to see you again during another anniversary. Well, I'm not speaking about the 200th anniversary. I hope that we will celebrate another university earlier. I like that the members of the team asked me, are you planning anything next year? If so, then let's start preparing tomorrow for it. I really like that they're not tired. They're ready to continue and prepare for large events. And out of respect for you, I will just stand up and applaud to everyone. Thank you so much. And goodbye. A safe trip back home to those who are leaving, and we're looking forward to seeing you in Tashkent. Thank you.